1, 2. Good morning. Good morning, everybody. Well, we'll go ahead and get the day started. So welcome to the 2019 AAKP National Patient Meeting. I'm Diana Kleins, Executive Director of AAKP. This year's meeting is a milestone event for the association as we celebrate our 50th anniversary. And we thank you all for joining us. Before we start the program today, I'd like to run through a few housekeeping announcements to help you plan for the next few days. We are offering complimentary Wi-Fi, generously supported by our friends at Amgen, in all meeting space. Please select the Hyatt-meeting and enter passcode Amgen 2019. And if you forget, there's little cards at the registration we can give you. We encourage you to post, tweet, and share throughout the meeting using hashtag KidneyPatients19. Breakfast will be available every morning in the exhibit hall, so please check your program book for times. While you're enjoying breakfast, please take the time to visit our over 30 vendors who are eager to share with you the products, services, and resources they have to offer. Be sure to get your exhibit hall passport stamped and return to the AAKP Registration Center for drawings and prizes. Don't forget to stop by the AAKP Wellness Center located in the exhibit hall this afternoon to talk to healthcare professionals and participate in some general healthcare screenings. A big thank you goes out to our local friends at Black Nurses Rock DMV chapter for hosting this year's Wellness Center and helping keep our attendees in tip-top shape. Be sure to check your tote bag for information on this year's AAKP social media game, which is something new we're doing. There are a number of fun activities you can do to be a top social media influencer at this year's program. And when you need to recharge, stop by our popular social media center, also located in the exhibit hall, to charge up. Be sure to use the props and take fun pictures with those you meet throughout the weekend and post using hashtag KidneyPatients19. AAKP thanks our friends at Retrofin for their support of this year's social media center. We will also be offering beverage breaks each afternoon, but if you need a midday snack, stop by the VitaFuel snack bar table located next to the registration center to purchase kidney-friendly snacks. We thank VitaFuel for donating back to AAKP a portion of all sales made throughout the meeting. And finally, be sure to stick around this evening for the welcome reception in the exhibit hall from 4:30 to 6:30 p.m. Light refreshments will be offered. And now I'd like to begin this year's meeting by introducing AAKP President Richard Knight. Richard is a former hemodialysis patient and current transplant recipient. He has a background in public policy and congressional operations based on both his professional experience on Capitol Hill, where he served in various roles, including communications, policy, and legislative director, as well as his advocacy work as a kidney patient. I'd now like to welcome Richard up.
Thank you, Diana. Good morning, everyone. First of all, I want to thank everybody for being here. I will try to follow the script. But, you know, we have worked towards this for so long, and it's really just exciting. I am overwhelmed by my fellow patients, their perseverance, their ability to turn out in spite of challenges that they face. I just saw my good friend Dale. I sent him an email this morning because I didn't think he was going to be here, and I walk into the hallway and he's there. It just blows me away. So, well, again, thank you, Diane, and welcome, everyone. Whether this is your first AAKP meeting or you faithfully join us year after year, it's important that you know that each and every one of you is part of the AAKP family, and we sincerely mean that. We say it often, and we're going to repeat it because it's true. We're the oldest and the largest fully independent kidney patient organization in the United States. We were founded by patients for patients. We make no exception for who we are and what we believe in. Our focus has been and will always be on those diagnosed with chronic kidney disease and those yet to be diagnosed. At AAKP, we have a rich history, 50 years, and be sure to check out the table back there to see some of the information from those whose shoulders we stand upon. Tremendous past and history we have. And we're honored to have with us a few of AAKP's past presidents with us today. We have Sam Peterson. Hope Sam is here. Okay, well, Sam is coming, but he's here. Miss Brenda Dyson. Right there. Hey, Brenda, how you doing? Thanks for helping out yesterday. Give them applause. And last but not least, my good friend Paul Conway, who is headed over here. Sometimes Paul gets into things that are above my pay grade, but he's been a tremendous help. And as the immediate past president, he continues to serve in a capacity that is just really, really overwhelming. So we're appreciative of those who have served in the past, and we certainly appreciate your service and the leadership that you provided to all of us. So again, just give him a round of applause. The next few days, not only will we be celebrating the legacy of patient engagement and advocacy, but we'll be celebrating a shift in the kidney community, a change to the status quo made possible by the recent executive order advancing American kidney health. Not since 1972 have we witnessed such a focus in kidney disease, and as a fellow kidney patient, I can say with confidence that this executive order truly puts patients first. Your voices have been heard. Change will not happen overnight, but it will happen, and current patients and those yet to be diagnosed will have improved care, full patient choice, and advancements, technology, and innovation that's needed to reduce the devastating impact of this kidney disease. AAKP is leading the charge to continue to insert independent patient voice across the entire kidney continuum. There's no better time than now than to be a part of AAKP and to lend your voice to ours. These next few days, you will not only learn, but you will be provided with the tools and the resources to be engaged in policy and advocacy processes and understand how to effectively share your opinion, experiences, preferences, needs, and journey with decision makers who are implementing the executive order. And that's something that I pride ourselves on, because that's not just something that we started. I think I counted just the other day that we've got between 75 and 80 different collaborators with whom we're working. And this is something that we have been doing and we will continue to do to help implement this executive order. But before we move into our opening sessions, I'd like to extend a few thank yous. First, to the 2019 National Patient Meeting Planning Committee, led by Convention Chair Lisa Garner. Unfortunately, Lisa was unable to join us, but for a good reason. She just received a kidney transplant and she's well on her way to a wonderful recovery. We speak with her often. She's in good spirits. It was tough. Many of you out there know what she has gone through and what she is currently going through. So, Lisa, we know that you're watching, and we just want you to know that we miss you, and we certainly appreciate all that you've done and will continue to do. So thank you for your hard work, dedication, and leadership. And thank your husband, David, for not letting you come. Sometimes patients, we get a little bit overzealous and do things that we shouldn't do, and we need that hand of reason. Usually it's the wife, but in this case it's the husband. So we will recognize the rest of the committee members individually on Saturday evening during our awards banquet. However, their support helped shape this year's program, and we're certainly appreciative of them doing that. And I'd also like to thank AAKP's professional staff. Diana Kleins, our Executive Director, you just heard from. Valerie Gonzalez, Director of Office Operations. Erin Kale, Director of Stakeholder Operations. And Deborah Pelias, Marketing and Communications Manager. My bosses. This, yes. I tell you, they're a very highly skilled group of professionals. They're dedicated, and they work tirelessly. And they've done that as they have many years. This year is no exception to plan a fantastic 50th celebration. So my hat goes off to them. And again, I really just want to thank them for their efforts and, quite frankly, their leadership. Many of you in here know them because when you call the office or you need something, or you ask me something, I say, call Diana. You know, they're the ones that really make things happen. And while I've been talking, you've likely noticed a looping set of slides behind me. So I'd like to take a moment and acknowledge this year's meeting sponsors for their generous support. Our platinum sponsor is Amgen Incorporated. Gold sponsors are Horizon Therapeutics and Mallinckrodt Pharmaceuticals. Bronze sponsors include CareDx, Next Stage Medical. Patron sponsors include Akebia, Dialysis Clinic Incorporated, Retrofit Incorporated, Baxter Healthcare, Bayer, and Hansa Biopharma. And our supporting sponsors are Advaccines, Nestle Health Science, Opco Renal, Somatis, and VitalFuel. Many of these company representatives are in the room with us now, and you can also meet them throughout the week and during educational sessions and in the exhibit hall and the various focus groups being held. So please join me in giving them a round of applause for their generous support, which demonstrates their commitment to AAKP. And I do want to say, you know, I was in the exhibit hall this morning, and which is why I was late. I was in the exhibit hall. You know, the executive order has placed more emphasis on kidney disease and what's going on, but we have such a strong and tremendous group of exhibitors here. It's a lot of information to be learned just walking through there. And I always take the time. I'm not the brightest person, so I have to be told several times. So I ask the same question over and over, and eventually it gets through. But for us patients, and even for healthcare professionals, caregivers, everyone here really, it's just so exciting when I go through there. I've been to other events, and they've had 2 or 3, you know, exhibits, but we can really spend some time there. So I always really like to impress upon the people that you really need to go over there and spend some time. One of the other things I want to take a few seconds to do, a few minutes. We're really going off script here. But wanted to talk a little bit about what's going on the national scene. And I thought one of the things that's on everyone's mind is the President's executive order advancing American Kidney Health Initiative. And, you know, overall, we've added some incentives. Notice I included we, part of the team. We've added some incentives that will, again, focus on the patient. And a lot of people ask me what I think of the different models and things of that nature. Well, you smart people and the docs are going to figure that out. My focus and my objective is to really look at this from a patient perspective and talk about how we can help implement this. And the beginning point of any strategy is some analysis. So I had to read because there are many of those much smarter than me that can do the analysis. But I just want to take a second and share with all of you, and certainly some of the patients, some of the thoughts that we had, and to talk about how realistic, although they may seem to be difficult, and they are, impossible if you believe that you're going to keep the same business model or system in place. But looking at the goals, reduce the number of Americans developing end-stage kidney disease by 25% by 2030. Whenever I'm at a meeting, I always ask, how many primary care physicians are in the room? And when I didn't know anything about dialysis in the industry, I used to always ask that question. Because my primary care physician, I don't want to name names, but it wasn't diagnosed. And I crashed on to dialysis. So I happen to believe, as somebody said, Richard, it's not that simple. And I turned around and said, oh, yes, it is. Why can't we diagnose the patients earlier? I don't understand that. I will not accept that as being difficult. I've always said, well, pay them. Oh, Richard, that's preposterous. Well, I think some of the new changes that CMS have made for the primary care physicians focus on paying them to make that early diagnosis. Seriously? So I don't think that's a stretch goal at all. I think that's something that we should have been doing all along. And it's simply unacceptable for it not to have been done. Oh, I don't want to alarm the patient. Oh, so you just let them have dialysis and go forward. So patients feel very strongly about that. And as one lady told me, well, you know, you guys aren't complying anyway. They probably told you. And I just gritted my teeth, as many patients do when they get insulted like that. So we think that that's something that's very realistic. Patients, we have to push for that. Anything else is unacceptable. You talk about low-hanging fruit, that's pretty low. Now, because many of us patients, and I say many of us, I'm really talking about me, aren't the brightest people in the world, I've asked for quite a while for the staff to develop a little card that we could carry with us. So when we go to the doctor, because many of us go to the doctor, primary care physician, and we forget, oh, I forgot to ask that question, and you're kind of being rushed out. Well, if you haven't seen them, we have some pocket guides out there, like you can see this little thing like this, pocket guides. Patients, I want to make certain that every single one of you gets that. And when you go to your doctor and you ask them if you've got some issues, they do the blood work, they do your urine analysis, you might ask them, what stage of CKD are you at? And once they tell you that, you'll pull out your little handy-dandy pocket guide. I wanted something small that you could put in your pocket. Not a brochure, not something big, pocket. We struggled about that. They didn't give me what I asked for. They're smart. They gave me something much better. So I appreciate that. Once again, that's why they do what they do. But the bottom line is that this will tell you, depending upon your CKD stage, it will tell you the specific questions to ask. Believe it or not, that's a powerful tool. That's patient empowerment. And ask the questions and get your answers. That's the first step to meeting the goal. The other thing is that early identification allows for you to slow the progression and educate the patient. The next goal, increase the number of new or incident American patients on home dialysis or transplantation to 80% by 2025. You can't do that with the current system that's in place. Can't do it. Because over some large number that you won't believe, 60-something%, go to dialysis, crash in there from the emergency room. Again, early identification, slow the progression, educate the patient. Docs say, well, you know, all patients don't want to do home dialysis. There's a concept called fear of the unknown. And if you have no idea what's entailed in home dialysis, who wants to stick themselves? Who wants to be in a room? Who wants to have this ton of supplies cover your house up? That's fear of the unknown. That's why early identification, slow the progression, you educate the patient. Educate. That takes away that fear. And that allows you, I always say to people, I'm not going to make a decision for you. My job is to give you information so that you can make an informed decision. That's what education will do, allow you to make an informed decision and allow you to select a modality that fits your lifestyle. And I think that we can make great progress as we approach that. And again, we've got to do a better job. We know that there's a shortage of kidneys. But one of the things that is never included in the numbers is an educated patient who has an idea, who can talk to others. We probably can increase the number of living donors because you'll know how to do it. And where's Jim Myers? He's somewhere in here, and he's always up on Facebook, putting a page up, helping a patient use Facebook as a means to get a kidney. You can't walk up to your friend and say, hey man, can you give me a kidney? But if they read on Facebook your situation, if they get some education, then that can happen. These are all things that are currently going on. So in the context of meeting these goals, I believe that it's more realistic, but you cannot stick by the current business model. It's called, this is not healthcare. This is called strategy and industry transition. And there's certain things that need to happen called driving forces. And this executive order has tremendously changed the driving forces. And some people will get it sooner than later. And there's a number, we're going to hear them throughout the sessions. Education, you have CVS, you have Somatis here, you have other people with different innovative ways to provide help to the kidney patients. So these things are happening. And the last one, double the number of organs available for transportation by 2030. That's a stretch one. You know, I just was invited to write an article for C. Jason, and I'll probably get skewered for that because I put this in there. You know, I read an article about over in France how, based on their standards, we could use 60% of the discarded organs. And people quibble about, well, that's not true and this and that. And it may not be true. But the question I have is, what are the best practices? Have we looked at what they do throughout the world? Maybe they're not appropriate here. If you've got 10 factors that are looked at when we determine the quality of that kidney, who's making that decision? If you ask a patient who's on dialysis, then if you tell them that you can give them a kidney that will last for a year or two, and you've been on dialysis, I'll take it. So I'm going to begin to wrap up here, but I just wanted to share that with everybody and let you know that everybody here in the room and the expanded community, we can make this happen. And from a dollars and cents perspective, in the long term, it's going to be a big saver. So, I'm back on script now. And I like to begin. Got the eye from Diana, so, you know, I got to go back on script. I'd like to begin our first general session, patient engagement and federal cabinet agencies, opportunities to serve your fellow patient. And this is a unique panel that's comprised of federal agency representatives, and they're here to share how you, the patient consumer, can get involved in the process, share your voice, and make an impact in policy. I'd like to introduce the speakers who will present in the order that they are introduced, and after their presentations, we will take questions from the panel. And because I've been not the best moderator, I'm going to rely on the staff to make certain that we stay on time and take the weight off me. I think last time Aaron was sending me emails and we went twice the time period. I got fired. All right, so I want to give this group as much time as possible because they've really got some great information to share with us. I mean, our federal partners do a tremendous job, the civil servants, and we can't thank them enough when they take the time out their schedule to come out here and share with us. So again, I'd like to introduce them, and in the order that I introduce them, if they would come up and give their presentations, then we'll have some questions. Dr. Patricia Modreau She's with the U.S. Department of Defense. Christine Schultz. She's with the U.S. Department of Labor. Dr. Paul Kimmel with National Institutes of Health, and Dr. Jesse Roach with the Centers for Medicare Services. And I'm going to turn it over to you, Dr. Modrew, to go ahead and start us off. Okay. Diana will assist you.
And I have a timer.
Oh. Defense, I take it on.
Okay.
You for not getting fired.
So do I just move them with this? Yes. Oop, okay.
They're moving over here.
Oh, okay. Excellent. Okay, perfect. Okay, so how many individuals know about the Congressionally Directed Medical Research Program? There's a few, good. So what I wanted to do was to just give a brief introduction, and I'll make it relatively quick since I have about 10 minutes to speak. So we exist because of you, plain and simple. We were created in 1992, 1993 when breast cancer advocates went to the Hill, and they demanded more funding for different and new innovative research for breast cancer, as they felt nothing had really changed in terms of treatment in about 40 years. So the appropriation came to the U.S. Army Medical Research and Development Command, which is part of the DoD. And we're located about 53 miles, actually 52.5 miles northwest of here. Of course, it's about a 3-hour drive, but that's beside the point. And so what's important to know is that every year, individuals like yourself, you go to the Hill, and that's how our programs are started, and that's how our programs continue. So it's on an annual basis, year to year. And the research that we support, we have currently have 33 different research programs. And each of those research programs comes with an appropriation, and that funding can only be used for that research program. And it's also important to know that in case someone complains, oh, why are you using DoD funds to fund this research or kidney research or polycystic kidney disease, it's because the funds don't take away from the DoD budget. These appropriations actually add to the DoD budget. So we did a couple of things. We went to what at that time was the Institute of Medicine. We asked for some guidance, and of course they always give you more guidance than you asked for, but still there were two hallmarks that I'd like to speak to. One was that we should not just have a traditional peer review that looks at the technical merit and then say, okay, everything that scores really high gets funded. We were encouraged to have a programmatic review, and that's the second tier of review. And what that does is that basically takes the scientific meritorious proposals, research applications, biomedical research applications, and we look at it for impact. What is the relevance on that disease or condition, and what is the impact? What difference is this research going to make? So we don't have a pay line from the best scoring till we run out of money. We actually do a comparison. And the other thing that has become a hallmark of our programs, all of our programs, is consumers. Individuals like yourself are involved in all aspects of the program cycle. And we also have a review criterion of both peer review and programmatic review for impact. So impact and relevance to that disease and condition. And I hope he doesn't mind, but I just ran into James Myers this morning, and he just recently served on one of our peer review panels for kidney disease. So it's important for you to know that you going to the Hill and asking for these funds does make its way to us, and we do listen to you when we incorporate the advocacy. It's a unique partnership. I'm not going to go over this slide too much, but basically, as a consumer, when you sit on our panels and involved in all our processes, you're an equal partner. You have equal say. Consumers, there's many different words that are used to describe a consumer. We use consumer review as someone that's involved in grant review, and consumer advocate, someone that actually participates as a research collaborator, not a test subject, but a research collaborator in our research proposals. So we've had, since 1993, over 2,700 consumers that have represented over 1,300 organizations that have served on peer and programmatic review. And typically, a consumer will serve anything from 1 to 5 years. So our program cycle, again, it begins with the congressional appropriation. But I wanted to show this slide because of all of the points in our program cycle. Every single one of our research programs follows this program cycle. And you can see every place where a consumer is involved. And again, the consumer has equal say on all of our panels. So we have a programmatic panel that does the vision setting, and that basically is they look at all the gaps, critical needs, immediate needs, and they set the vision for the year. And then, like myself, staff, I go and I prepare what we call award mechanisms, and we release those as funding opportunities. We have a pre-application receipt that we usually do an invite and not invite. And again, as a consumer, you have equal say in terms of deciding what gets invited for a full application and what doesn't. And then after we have our proposal receipt, consumers sit again as equal partners on our peer review panels, where you sit with those bench scientists as well as clinicians in determining the scientific merit of the proposals. And following that, as I said, we make our funding recommendations at programmatic review. And again, as a participant in the programmatic panel, you also get to make recommendations in terms of what gets funded and what doesn't get funded. So as you can see, you're integral to our processes. So to be on our programmatic panel, we usually look at those that have served at peer review to bring them into the programmatic panel, or we reach out to the advocacies to see who are the leaders in the field as consumers. But at peer review, we have a slightly different process. But it's important to know that in participating in our programs, that you really need to be an active participant in some sort of advocacy or outreach or support organization, and to be nominated by your organization. And it's also important that we don't expect you to come and speak just for yourself, but you're speaking for your community. This is your opportunity to speak to all of your fellow advocates, your fellow consumers. And different programs use consumers differently. For example, ovarian cancer. To be a consumer on the ovarian cancer research program, you need to be an ovarian cancer patient or survivor. For something like Rett syndrome, it's one of the topics in the peer review medical research program. Since the individual can't be a consumer or be represented, usually it's a family member. When we have topics, and I also manage the peer review medical research program, which has all of the kidney disorders and diseases, it really depends. For that, we look at someone like yourself, a patient and a survivor. And we have several steps in terms of submitting an application, a nomination by your organization, as well as a CV, and a personal statement, because we're really looking for that commitment. And we have a contractor, it's GDIT, that helps us with this, and there's someone called a consumer reviewer administrator that actually reviews your application and conducts a telephone conversation with you to see if you really have a commitment and you really would like to do this. On our website, we have a whole section about consumer involvement, and we have some information about us. Frequently asked questions. People have questions. What do I have to do? What does it mean? Am I going to be intimidated? And so we answer those questions, and then you can pull down the application package. And consumer review administrators also work very, very closely with you in our peer review. As well, we also work very closely with the consumers at programmatic review to make sure that you understand what you need to do and that you feel comfortable and not intimidated. And when consumer review is that a nominated or are reviewed, we look for your commitment to advocacy, your commitment to making a difference. That's really what it is. We don't expect you to know the science, but we expect you to be willing to learn the science and really to speak for your community, and also to think about what is the impact? What difference does this research make? That's really what you bring to the table, because if the research, it can have an immediate impact or it can have a long-term impact. But if it's not going to have any impact at all, then what good is it? I mean, research is good for research's sake, but that's not what our research programs are about. And again, we ask that the consumers bring a sense of urgency, because I think that's really important. Because on our panels, and I think on most review panels, you have bench scientists that often don't have firsthand knowledge or experience with the disease or condition for which they're either doing the research or for which they're reviewing. So as consumers, you really bring that experience, and you bring all those nuances that are associated with that disease or condition that the bench scientists don't know. And even the clinicians, although they're very knowledgeable and they may treat you, I don't think they have, if they don't have the firsthand experience that you do, then they don't always understand what you're going through. So one of the last slides I want to show is there's another place that you also participate for several of our, and that is in the research effort. And several of our programs and other funding agencies, including NIH and Susan B. Komen Foundation, not only require but sometimes encourage consumer reviewers or advocates to be involved in the research. And we don't have any in the peer review medical research program, but we do have in some of our other programs. And that really is what we don't just require someone to say, okay, I'm gonna participate as a test subject, or I'm going to reach out and try to get you specimens, et cetera. When we ask a scientist to include a consumer in a research effort, that means that they are to be considered to be equal partner and be part of the research design as well as part of the team collecting the data. So we see consumers as our true north and our compass. You are the reason why you exist, and you're the reason why we continue to exist. You're involved in all parts of our program cycle, and it's really the impact on the research on your kidney condition that we're interested in. What is the impact of this research? And we demand that there's innovation, we demand that there's impact, and we ask that you bring that to the table. And bring your perspective of your peers, and really put, as Mr. McKnight said, bring the urgency forth. And that's what we ask the consumers to do on our panels. And also then we ask them to take the message back home to the advocacies and to their fellow comrades, to let them know what we do and how we do it, and how if they participate in our programs, what a difference you could make. So with you, and with the way that I think we handle our program cycles, we hope that we're providing hope. Thank you.
Good morning. My name is Christine Schott. I'm with the U.S. Department of Labor's Wage and Hour Division, and I'm here to talk to you today about the Family and Medical Leave Act. And it's truly my honor to be here before such a wonderful organization. I want to give you two pieces of information for you to get more information about the FMLA that you can't get from me today. First, the phone number so that you can find an office to talk to a person. That is 1-866-487-9243. We also say 1-866-4-US-WAGE. We have Wage and Hour Division offices all over the United States, and every state in multiple offices in the larger states. So, if you want, and if you have questions about either your own or your family members' workplace rights, that's a good start. Secondly, the Wage and Hour Division website has a lot of information, especially about the Family and Medical Leave Act. So if you go to www.dol.gov/WHD/FMLA, you can find all of our information. You can also just go to dol.gov and dig your way there. So the Family and Medical Leave Act was passed in 1993, and the law it provides two basic entitlements to employees. One is that for certain qualifying reasons, employees can take time off from work without having their job put at risk. So employees can take up to 12 weeks of leave in a leave year, provided that the employer is covered by the law and they're eligible under the law to take FMLA leave. An employee can take up to 12 weeks of work and of leave from work, and that time that they take off should not be held against them. They shouldn't get an attendance point. They should be able to come back to work at the status they were when they left. The other entitlement, the other main entitlement of the law is that employees who work for an employer who's providing a group health insurance benefit, that employer has to keep the group health benefit going while the person is out on leave. So the employees should be informed of what their obligations are before they go out on leave to either make payments if they're out on an unpaid leave, or to make up for payments they're not able to make when they come back to leave. So those are the two main entitlements, and that hasn't changed since in the 25 years that the law's been out there. The law has been amended two times, but what happened with those amendments is that there were new protections, leave entitlements provided for military families, and then the other amendment is that for our employees who work as airline flight crews, there's special rules so that they can be eligible for FMLA. And very quickly, for employees to be eligible for FMLA, the employee has to work for a covered employer. In the United States, an employer is covered by the FMLA if it is a public employer, so all state agencies, all city and all federal government, most federal and government employees are covered by the law. Secondly, all schools, elementary and secondary schools, are covered by the FMLA. And thirdly, employers who have 50 or more employees, employers in the private sector with 50 or more employees will be covered. Employees can be eligible to take FMLA leave if they work for a covered employer, if they work for that employer for at least 12 months, and if, with the exception of airline flight crew employees, if they've worked at least 1,250 hours in the year preceding the need for leave. So what are the reasons that employees can take leave that's protected by the FMLA? So under the FMLA, there's not a list. That when the law was passed, Congress didn't say these are all the different types of sicknesses that you can have that would qualify you to take FMLA leave. So it's more of an umbrella system. One umbrella of reason that employees can take leave is that the employee is expecting a baby. Either they're having a baby or they're adopting a baby. So a person can be a baby or a child. So you can take FMLA leave for the birth or adoption of a child. And the other big umbrella is that an employee can take leave if they have a qualifying serious health condition, what the FMLA calls a serious health condition under, the employee can take leave if they have a qualifying serious health condition. But also, an employee can take leave to provide care for a family member who has a qualifying serious health condition. And the definition of a serious health condition under FMLA is it covers two broad categories. It can be a condition that requires inpatient care. It can also be a condition that requires continuing treatment by a healthcare provider. And then under those two definitions, we also have a number of particular categories that are that the law recognizes as types of qualifying serious health conditions. So you can have, for example, a chronic condition where an employee, where the person may only need, they may only see a healthcare provider a couple of times a year, but they have a condition that can be incapacitating. That can be a qualifying condition under the FMLA. Also, a condition that's not chronic, but that is short-term in nature, but the person, but that incapacitates a person for more than 3 days and requires some care by a healthcare provider. That can be a qualifying serious health condition. And also conditions that are permanent for which treatment may not be effective. Those can be qualifying serious health conditions. So there's a range of types of conditions. And again, the law doesn't say that this particular condition is in and of itself is a serious health condition. What the law says is that how that condition affects the person is what would make it qualifying under the serious health condition. So if it's the employee has a condition that's making the person incapacitated and unable to work, then it's potentially a qualifying serious health condition. It doesn't matter so much what the name of the condition is or what the diagnosis of the condition is. To that end, I wanted to talk with you a little bit about a particular guidance that the department put out last year in August of 2018. We were asked, the Wage and Hour Division was asked, as far as the definition of a serious health condition, when a person donates an organ to someone, is it a qualifying serious health condition under the FMLA? And the department said very directly that, of course, donating an organ can be a qualifying serious health condition. First of all, if the definition of a serious health condition includes circumstances when a person is hospitalized overnight, a single night, and the recovery from that hospitalization, that's almost always going to cover the situation of a person who's donating an organ. Another kind of follow-up question to that is, does it matter that the individual who's donating the organ is not related to the person who is the recipient? And of course, it doesn't matter. Again, when we've published an answer to this on our website as well, it doesn't matter that the individual is not related to the person that's receiving who's the recipient of the donation. If the employee, him or herself, is taking time off to donate an organ, they don't have to be related to who is the recipient in order for that to be a qualifying serious health condition under the FMLA. By the same token, if a person is donating an organ, their family members who are qualifying under the FMLA to take leave for their care, they can. So under the FMLA, a person can take leave because of their own serious health condition or to provide care for a family member with a serious health condition. And those qualifying family members in the FMLA world are the person's spouse, the employee's spouse has a serious health condition, or the employee's son or daughter, or the employee's parent. So if an individual is donating an organ, the spouse of that individual could take leave to provide care for that person related to their time in the hospital and their recovery. Those were the main points I wanted to share with you today, and I thank you again for your time, and I look forward to the questions at the end. You're welcome.
Thanks for inviting me. Happy 50th birthday. And I just want to tell you, I'm glad that you're younger than I am. I have 3 take-home messages to tell you about today, but I really want to tell you before that about the genesis of this talk. I decided that I wanted to have a conversation. I wanted to present some ideas so people would listen, we wouldn't be distracted by slides, and I would look forward to questions and answers, and that I would really make an invitation during the talk so that people would listen to me and be attracted to me. And then I got anxious because I thought that everybody in the panel would have PowerPoint and what would happen. So I called my psychiatrist, and the psychiatrist said, you know, you have to do what you have to do, and you have to think very carefully about decisions, and every decision is grave, and there's import to it, and you really have to give this some thought. Then I spoke to my wife, and she said, everybody's going to have a PowerPoint, and if you don't have a PowerPoint, you're not going to know what to say, and you're going to start to ramble and go off speed, so you should have a PowerPoint. So my wife frightened me and made me anxious. And so yesterday I made this PowerPoint, and it was succinct, it was beautiful, it had some pictures, it was just gorgeous. And when I looked at my USB this morning, it wasn't there. So I called my psychiatrist, and my psychiatrist said, you really didn't want to give a PowerPoint. And then I spoke to my wife, and she said, you never listened to me. So my 3 take-home messages are these. The NIDDK apologizes, your institute, your research institute at NIH, because we're late to patient engagement. The NIDDK, however, unfortunately, is in a leadership role at NIH regarding patient engagement. I was recently at a multi-institute conference, and the only institute that was ahead of NIDDK was the Cancer Institute. So I was gratified by that. I understand that we have a long way to go. I particularly am a Johnny-come-lately. I learned about patient engagement to solve some specific research administrative problems, and I'll tell you about that in the next 10 minutes. But the third message is NIDDK now is deeply and firmly involved in patient engagement at all levels. And I liked what Dr. Madros said about the review process where patients are involved in all levels. That's the way we want to do research involving human beings at NIDDK, that they should be involved at all levels. And just to tell you about the importance of this at NIDDK, my organization, we have a council meeting 3 times a year. It's like the board of directors. And Richard Knight, your president, applaud. That's enough, that's enough. We only have 10 minutes. And representatives of the diabetes community and the GI community are all going to give talks to the council, to the whole NIDDK, to scientists, to administrators, talking about the importance of patient engagement and talking about what their organizations are doing regarding patient engagement. So that's a tremendous commitment on the part of a big research bureaucratic institution. It also means at the end of this discussion, I'm going to ask all of you to participate. We're starting some new research programs, and I'm going to be consulting with the leadership of AAKP to find patients who can provide their voice to researchers, say to speak truth to power. So we've had several big studies within NIDDK, the MDRD study, the study of diet and blood pressure control in patients, the ASK study, the African American study of kidney disease, and the chronic renal insufficiency cohort. The ASK study had no patient engagement, studies from the 80s. The MDRD study had no patient engagement. Doesn't mean we were bad people, it's just the ethos of the time didn't include that kind of idea. The CRIC study is 18 years old, and they're being pushed by NIDDK now to put patients on all their committees, to empower the patients who are giving them the data that they're going to use, and I think we're succeeding. So how did I get involved in patient engagement? I'm probably the leading advocate of patient engagement right now in NIDDK, and I'm very proud of that. but I didn't do it because somebody told me to initiate patient engagement. We had a study that I was involved in where we were going to ask patients to be volunteers where they may be at some risk. And you may have heard about the KPMP study, the Kidney Precision Medicine Project. I'll be speaking about that at a lunch table this afternoon. And that project is because we have made, although we've made some advances, we haven't made fundamental advances in understanding acute renal failure or acute kidney injury and understanding CKD. So we have some treatments. We have very effective treatments in terms of blood pressure control, interruption of the renin-angiotensin axis with CKD. In AKI, we have really not made much progress at all, and our feeling scientifically is we don't really understand the pathways, we don't understand the mechanisms, we don't understand what drug targets should be used. And after several workshops, which involved patients, which involved scientists, the answer sort of emerged that if you don't have biopsies, if you don't have human tissue that you can put under a microscope, that you can smash the electrons of, that you can do all kinds of atomic analyses, omics you may have read about in the newspapers and magazines, you're not going to understand how to treat the disease fundamentally. But when you do a renal biopsy on a patient who usually doesn't need a renal biopsy but has a kidney disease, there's some risk. Between 1 in 1,000 and 1 in 8,000 patients will die as a result of that procedure. So that's a tremendous ask. It's a very small risk. It's like the risk of a tonsillectomy, but it's a risk that wouldn't be undergone otherwise. And when we struggled with how we were going to start a research project, we started a workshop. And in this workshop, I said, we're going to have 4 or 5 patients in this workshop talking to us, listening to us, responding to us, being on the committees to tell us how they felt about it. Was it reasonable to ask for this kind of renal biopsy program? And we had some members of the AAKP leadership. We had one of my patients from GW participate. And along with ethicists, with members of the FDA, and with scientists at the NIH, the conclusion was it's ethical to go forward and do these kinds of biopsies with patients participating in the research if the patients are informed, if the patients know what the risks are, and if the patients, the participants, are willing to do that and are eager to participate in the study for altruistic reasons, not because they're going to benefit, but because future generations will benefit. The most important participants in those discussions were not the FDA, were not the ethicists, and were not the scientists, but were the patients who said, I would have a biopsy again if I knew that it could be involved in a cure. And it's an incredibly important voice in government documents and sterile documents when we say we had 6 patients who endorsed this program. So what we did was we set out in the government, it's called an RFA, or request for applications. And in the application, we said, you want $500,000 to do these tests? Great, write a very scientific application, but on your team, you have to have 2 patients. You don't have 2 patients, we're not going to consider your application. Very good science, no patients, no good. So at our first meeting, we had 100 scientists, and we had 15 patients in a room just like this. And I led off the meeting, and I said, look, I know there are patients here. You know, you may not feel well, you know, across the course of a day. You may only want to attend 2 hours of a session. You may not want to spend 8 hours in a medical meeting like I do because I love it. I understand. You want to go visit the Washington Monument, that's fine. You want to stay in the hotel room, have a nap, you know, from 10 to 2, that's great. Don't worry about it. I have been shocked because at these KPMP meetings, almost all the patients stay in the meeting all day because A, they want to know what's going on scientifically, B, they want to tell the scientists what they think, and I'm one of the leaders, and I encourage those patients to call the scientists on any aspect you want. What did you mean when you say the X, Y, Z, the LE, right? What does that mean? It's perfectly acceptable behavior. And we want the patients to ask questions and to be involved. And the patients have turned out to be as important participants as the scientists. So sort of what you were saying, Dr. Modrow, we're having the patients at all levels of the interaction. So I was personally surprised by that. What did the patients do in the KPMP? They wrote the first draft of the informed consent document. Nobody likes to sign those informed consent documents. They're 60 pages long. They have lawyer stamps. They have all these things. You can't even read them. You can't understand them. So the patient said, we want a one-page document. Everybody said, that's great. Then when the patients had to work with the IRBs, and the IRB said, no, we need 6, 7 pages, they understood the reality of creating that document. I think it was important for us and important for the patients. But I think that when you say to a regulatory body, a data safety monitoring board, an IRB, this is the way we want to do the study because the patients were involved with us from the very beginning. The patients wrote this informed consent. That has tremendous heft. And just to tell you what happened in KPMP, how many of you have signed an informed consent document for a research thing with a hospital? Right? There's that little paragraph that says, if you're injured in this study, the George Washington University won't pay 1 single penny for you, right? You remember that little line? It's in all the informed consent forms because it's part of the language that the hospital wants. They don't want to be involved in committing to pay for care out of a research study. Now, of course, they would have to do that if it happened, but legally they didn't want to. The NIDDK worked with the investigators so that we spoke with the deans, the CEOs of the hospitals, the heads of the IRB, and said, would you like to have the $500,000 of grant money? Would you like to participate in this research? They all said yes. Well, if you don't take that clause out, you can't play. And isn't it amazing? Every one of those big national hospitals, they knuckled under. So because there were patients in the KPMP, the United States informed consent process and the relationship between hospitals and patients in research studies has fundamentally changed forever. And that was a dramatic thing. It just happened in August, and I'm very proud of playing a role in that with the patients. Patients participate in the DSMB. Patients participate in the EEP. Paul Conway is one of the EEP members, and he keeps us very honest. He's quite eloquent. He says, I may not understand some of the details about the omics, but here's what you have to do about communication and respect. It's very powerful. What does EEP? EEP means the External Expert Panel. So it's a regulatory group within the study. But as Dr. Modrow said, patients are involved at every level, from the design to the regulation. So that's very exciting. I'll tell you briefly about the Apollo study. Mr. Knight talked about this very, very early in the session. It's a study of looking at how genetics may affect transplant outcomes in kidneys donated by African Americans. So because we had started to use this language where there were patients called for in each one of the sites, we had that in the RFA. When we brought the research group together in Bethesda 2 years ago, it was really amazing. All the investigators were white. All the patients and participants in the prospective study was black. This looked terrible to me, and it looked terrible to the leadership of the NIDDK. What were we going to do in such a case? Well, Luckily, I had put this clause in the RFA saying each site had to appoint 2 patients who had a personal relationship with transplantation or kidney disease. Suddenly, we had a council of 26 African Americans involved in the study from the very, very beginning. And they talked with the investigators. They did the same kind of thing they did in KPMP. They talked about language that they didn't like in the informed consent, language that they liked in the informational materials, tips about how to approach patients, tips about how to be culturally sensitive, and it made it a much better study. So I think that the Community Advisory Council has done a wonderful job, and we have Patrick G. and Glenda Roberts in the room who are on that council, and if I said anything that's wrong, you tell me and you tell the audience. They're quiet now. You can give them some applause. They've done a wonderful job on that council. Not only that, but patients serve on the steering committee. Nicole Jefferson, who I think many of you know, is a steering committee member. So she's as important as the NIDDK, as the steering committee chair, as all the scientists who are in this study. And we take what she says seriously. So when our EEP, that external panel, went and reviewed some of the things that we wanted to do with return of results, a very hot topic, the patients had said they wanted to have a variable return of results policy. Some people want to know their genetics. Some people don't want to know their genetics. So the EP didn't like that. And what the response was this was developed by the patients. And so we overruled the EP, and the patients specifically wrote to the EEP saying, if you want to see what we function as, come to one of our meetings. You're invited. They never came. I'll tell you about 2 other studies, and then I'll wrap up. We're just starting the HOPE study. It's a study of patients on hemodialysis who are receiving opioid prescriptions. It turns out that 20% of American dialysis patients receive more than 90 days of opioid prescriptions. We're just starting this study in 2 weeks. Patients will be at that meeting. Dr. Schmidt, I'm expecting patients from West Virginia to come to that meeting. Don't tell me they won't be able to come. Don't tell me they won't be able to be dialyzed in Washington, D.C. I took down the stuff from the front of the AAKP saying who to call, David and Fresenius, to make your appointments so you can have dialysis in D.C. And patients will be on the DSMB, the Data Safety Monitoring Board. They'll be part of the regulation. We had a workshop on acute kidney injury in January of this year in Bethesda. We specifically invited patients. They were on a panel like this. We gave the patients 2 hours to tell their stories. When we started the meeting, all the doctors said, what are we going to look for when we do an acute renal failure study? Well, we're going to look what the creatinine is, and we're going to look what the protein is, and we're going to look what the CPK is, and we're going to look what the, whatever it is. At the end of the meeting, the physicians changed to say, we're going to look at the end of the study with patient satisfaction with care, patient quality of life, patient function, and patient ability to cope with disease. Not only was that a great achievement for patients, but my peers listening to this discussion said, oh my God, we would have never come up with a patient-centered view of it. That's the way to go. That's what's important. So that's how patients can help. I want to just mention the Kidney Health Initiative, which I've learned a lot from watching all the patients participate in that group, which is co-sponsored by the ASN and the FDA, and noting that the FDA has done a tremendous job putting patients on their panels, listening to their voices. It's fundamental. So now patient engagement is key for NIDDK. It's going to be part of our council meeting. We will have, in general, I've spoken to NIDDK, I think we will have a patient voice involved in all our requests for research, in all our cooperative agreements, in all our clinical trials, in all our oversight groups, and in all our workshops. So, just to summarize, patient engagement and IDDK is new to this effort, but we have embraced it wholeheartedly. I personally became involved in this serendipitously. It was on-the-job training for me. But now, I think this is the most important thing that I've done in NIDDK over the last 5 years. And when people ask me officially, that's what I say, and they don't complain too much. NIDDK is committed to patient engagement right now and for the future. And as part of this commitment, we're going to call on you. I'm going to speak to Richard Knight and Paul Conway about patients who would like to participate in the HOPE study as consultants and as members of DSMBs, and I do hope you will serve. So patient engagement has changed my life. I will give you one caveat. It's very hard to evaluate scientifically whether it makes a difference in outcomes or anything, but I feel amazing power in such relationships that I never felt before in a study. So I can't give you the results of an RCT, I can't give you a p-value, I can't give you standard deviations and a 12.5 plus or minus 1.2, but I think it's made a big, big difference, and I hope you will contribute. Organizations like this are fundamental to federal agencies. So I want to say thank you, and I'll be very happy to answer any questions when we get to that period.
Thank you. I'm Jesse Roach. I'm a nephrologist that works at CMS. Dr. Kimmel, I brought slides.
My wife told me
You should always believe your wife. Listen to your wife. I've learned that, actually. It goes badly for me when I don't. In any case, I'm here to talk about the end-stage renal disease treatment choices model, as well as the Kidney Care First model. So just a little bit of background. I'm trying to see how do I advance this. Next. So this is a bunch of, it's mostly gibberish, but it has the website where they have the listing of the rule, which is what we need to do to implement this program, which I'll explain a little bit about. We're accepting comments until the 16th of September, if anyone would like to read this and make comment to the government to help us develop these programs. So I'll talk about first the Kidney Care First model. So basically at CMS, just the overview, as everyone knows, Medicare pays for end-stage renal disease treatment. In 2015, the Center for Medicare and Medicaid Innovation started these models, which wanted to change how we pay for ESRD care. We thought that we could use payment to drive improvements in care and to make care more efficient. So the idea was make facilities and organizations responsible for the entire care of a patient with kidney disease and give them financial incentives to do so. So the offshoot of that is that these new models, which are set to start in 2020, which are one of the things authorized by the President's executive order on advancing kidney health. And the addition to these are that we're going to extend this to patients before they get end-stage renal disease. So we're going to identify patients that have stage 3 and stage 2, 3, and 4 chronic kidney disease and trying to prevent them from getting end-stage renal disease in the first place. So that was one of the important parts of the executive order. It's also something that we heard a lot from patients, and most of these things we heard from had their genesis and hearing a lot from patients. It's amazing. So I practiced in Wisconsin. It's amazing what people will tell you when you're no longer their doctor, and so so I got a lot of honest feedback from people, and I appreciate it very much. So this will start in 2020, run through 2023, and we'll evaluate it to see if we're going to continue it. So this is just what we talked about. So the goals of these models are to get people with later starts on hemodialysis if it's appropriate, and then better starts. A large number of starts on dialysis are people that, as Richard had said, crash into dialysis, start with a catheter, start in a hospital. The mortality rate and the hospitalization rate is very high for people that are starting dialysis, and it's bad for patients. And so that's something that we want to change. We want to detect it earlier, and we want people to have smoother starts. We want better coordination of care, so we want to encourage facilities and organizations to talk to one another. So when a patient goes into the hospital, we want them talking to the dialysis unit so things aren't missed, and so there's not that inefficiency. We want more people to get kidney transplants. One of the goals of the executive order was to double the number of transplants by 2030. I don't know if we're going to get there, but I think it's a very good goal to try. I think we need to do this by encouraging people to think about transplantation more, and I think we need to do it by educating patients more. One of the things that I heard is that people, when they started dialysis, they didn't hear about transplant options, and they didn't hear about options for dialyzing at home. And so we want to put part of this as educations to make sure that people are hearing about these options, because you can't ask for an option that you don't really know about. And then some of these other things are payment reforms and other benefit enhancements. But the gist of it is we want to encourage organizations and facilities to do more transplants, educate their patients better on the options that are available to them, and work with them to provide better care. So this is boring. This is about payment for doctors. And so I didn't tell you, Dr. Kimmel, that making the PowerPoint slides, I don't like doing it, and it's a pain because I have to get them cleared by like 5 levels, so I just stole these from somebody. And so I will break away from this, and I will talk about the end-stage renal disease treatment choices model, which is the first model that I talked about, the Kidney Care First, the comprehensive kidney care model, is currently we're working out the details on that. But what that's going to be is a voluntary program that facilities can opt into it at various levels for them, and the details of that will be forthcoming soon. They're not quite ready yet. The thing that you can comment on, which I talked about right now, is the end-stage renal disease treatment choices model, which is basically going to be a mandatory model. So we're going to have about half of the facilities in the country participating in that. And what it does is it's meant to encourage the use of home dialysis, the use of transplantation, and we're going to measure and financially incentivize organizations to offer these to patients, and also to encourage it. And if somebody starts on home dialysis, we want to encourage them to stay on home dialysis if that's what they want. We want these choices available to patients. I heard a lot, and I've met with a lot of patients that I've gone to meetings that just focus on home dialysis. One of the things we always hear is, and not everybody can do it at home, but a lot of people want to do it at home and don't feel like they had that option, or they didn't feel like they had the support once they were on home dialysis and it wasn't successful. And we want to encourage home dialysis for people when it's appropriate for them. We also want to encourage transplants. there are a lot of people that don't know about transplantation, and there are people that don't want to do it, and that's fine, but we feel like you should be educated about that option, and that we feel that when most people are educated about it, that's something that they're going to want to pursue. And it's better. It's better for your long-term, it's better for long-term outcomes to have a transplant than being on dialysis. So the take-home points of this are, we can do a better job of delivering kidney care. We can do a better job of detecting kidney disease, stopping people from ending up on dialysis or needing a transplant in the first place. And we can do a better job of taking care of you once you've reached that, in terms of better outcomes on dialysis and giving you more choices for what to do once you get a diagnosis of end-stage renal disease. And I just want to say, in terms of patient involvement, it's been great. I've been at CMS for about 3 years, and it's speaking to so many patients. I've met a bunch of people in this room. I have worked a lot with Paul Conway and Richard Knight, and they've been great to work with. And I feel like every step of the way that we've been developing this, we've had lots of patient input. No one has really been scared to come up to me and tell me what they think, and I like that, and I please continue doing that. And I think that we are doing this with patients in mind. We've done this with tons of patient input, and we've done it driven a lot by what we've heard from patients at meetings like this and at various other meetings. It's refreshing. I actually can't think of a meeting that I've been to that didn't have some type of patient involvement. So, and I've been to quite a bit. So, so this is just the next step. So we're going to have the voluntary model, the one about the comprehensive kidney care disease, where we're going to look at patients that have earlier stages of kidney disease. The details of that will be out soon, and so those will be able to be commented on. And then I had mentioned before the other model that's already out, and we're accepting comments on that. So I just want to thank you all for having me. I'd like to wish the AAKP a happy birthday too. And for some reason, I'm happy that I'm younger than the AAKP, but well, I guess that's neither here nor there. So thank you guys, and I guess we'll take questions now. Yeah.
Thank you, everyone. Well, let's have some questions. We have answers. Maybe. Sir, can you step over here to the mic, please?
You know, we're on the cusp of a revolutionary and civil rights movement for people with kidney disease. But and I believe the professionals that have been in the forefront of this particular movement, as well as the exemplars in the oncology field that have set really a pace for interdisciplinary collaboration. But I have a question for you, Dr. Roach. From my experience as a patient with 7 years of dialysis, 2 years post-transplant, I've come to realize that there's a myth about kidney patients, that kidney patients are depressed. I mean, the fact is, diagnose someone with end-stage renal disease, and who wouldn't be depressed? Face validity, but from my experience, there's a degree of engagement, socialization amongst kidney patients. You can see it in the waiting rooms of dialysis centers. You can see it in meetings like this, and it's different than classical depression. And it invokes the question of how do we evaluate and educate patients, and how do we engage them dealing with several issues. Number one, we have a diverse population. Many of them are not native English speaking. Many of them, in fact, may be very, very bright, but don't respond to PowerPoints, and therefore require different educational modalities. How do we evaluate their cognitive functioning, the physiological impact of kidney disease and dialysis definitely causes some degree of impairment, some of which may indeed be reversible, but I think it affects the way in which we have to engage patients and approach patients. So while it makes perfect sense to talk about the connection between the competent patient, it's a serious issue. How do we deal with patients who are on a continuum of impairment and help them to get to that point of recovery that we want to get them to? Thank you.
So I do think that you're correct in that, and I think in terms of the payment issues and how that's our lever of sort of doing things. I think that when we make policies, we make sure that we are evaluating the education level. We have had focus groups where we've gone out and talked to patients to see what things we need to implement, and we made sure that we did them in multiple areas around the country, and that we did them with English and patients that spoke other languages, primarily Spanish. I think that we are very cognizant of, we have people that evaluate our materials and evaluate our rules to make sure that they're appropriate for all levels of education, intelligence, and just sort of general functioning. I think in terms of people being on dialysis and being depressed, I do think that some of it is due to having a chronic disease, but there is a definite large number of patients that have the actual depression. I think that doesn't need to be ignored. I think that we have implemented policies to encourage people to find that and to work on that, and to treat that when we encourage people to actively look for that and to treat it whenever it's present. And I do think that that's an important part of the care of patients with kidney disease that shouldn't be overlooked, and we don't. It's an important part of how we're encouraging patients. In terms of the cognitive decline that can happen with patients on dialysis and patients with kidney disease, I do know that it's something that we're aware of, and it's something that top men or whatever, are looking at in terms of research things to look into that. I can let Dr. Kimmel speak more to that aspect and other aspects of the question.
Thanks. You answered it so nicely. I'll be very brief. I started as a dialysis doctor about 40 years ago, and at that time, everybody said, well, patients are depressed on dialysis because dialysis is depressing. There has been, over 40 years, a tremendous change. Now, the study of psychosocial aspects of disease, how patients adapt to changes in their life is very important. It's taken seriously by NIH. It's taken seriously by practicing physicians. And there's a whole new generation of dialysis doctors who are different from those of 40 years ago. The HOPE study that we are setting up is specifically going to look at the issue of pain in dialysis patients, but balanced with the fact that that may be associated with depression, anxiety, poor social support, poor family structure, poverty, and to look at the patient as a holistic individual. And we have 8 major medical centers involved in this study, and I'm hoping that over the next 20 years, there's going to be a new generation of people who are interested in patients as human beings rather than billable objects. So I think you're right, and you got to keep speaking up.
We have time for 2 more questions, but are you guys going to be around for a little bit after this session? So feel free to approach them after we have these 2 questions, and they'll be able to speak with you. Go ahead, Glenda.
I'll be brief. Dr. Roach, I'm very excited that you're going to educate people so that more people are interested in being on the transplant list. But that also means that you're going to increase the number of people that are on the wait list. Could you elaborate a little bit more about what you're going to do to make sure that there are more organs available for the people that will now be educated and want a transplant?
So, I can comment on things generally, but we're in the process of writing regulations, so I can't comment on anything specifically. But part of the executive order was to, one, help people that decide to donate a kidney, so to find ways to offset some of the hardships and the financial difficulties associated with doing living donation. And then another thing that we had was, that specifically was in the executive order, was to use the regulations on the organ procurement organizations, so the organizations that are responsible for getting the organs for transplant, to decrease the amount of kidneys and other organs that are discarded, and to encourage the recovery of more organs. And so we're in the process of writing regulations on actually both of those things. And so that's what we're doing right now. We realize that if we increase the number of people on the waiting list, that we're going to increase the number of organs that we need. But we're taking active steps to work on that.
See, and just so you know, we have a session on that. That will be, is that today or tomorrow? The breakout session with CMS? It's tomorrow with some of your colleagues, Dr. Roach, and we'll be talking on that very issue, so join us tomorrow. Go ahead, Miss.
I was just wondering about the research projects with both the DOD and the NIH. I have service-related kidney disease. I am a transplant patient. My husband is also service-related kidney disease. He is currently on dialysis, and we would be more than happy. I'm a retired hospital corpsman, surgical technologist that can fit in anywhere, and I'm an educator. I educated for 15 years, so there's a lot of us out here that would like know the system inside and out.
I would recommend you talk to James Myers, but also all you have to do is Google CDMRP, and on our website there's that consumer involvement, and you can also contact us. There's a way to contact us on the website too, and feel free to to get yourself nominated, but feel free to also to contact us and ask. You can ask to speak specifically to me if you'd like. Do you have anything else?
Briefly, NIDDK would like to be able to reach out. I tried to do that in my talk, to people who would like to be partners with us in research, and I think maybe Diana will set up some kind of listserv so that we'll be able to, usually we're bureaucratic, so we go through the leadership, So if the leadership knows who's interested, we can use that group to come to workshops, get to know each other, and then we can go to higher and higher levels. But thanks for your willingness to participate.
Or I'll ask the moderator for the next session to be patient.
Okay, 10 seconds. I just want to, especially Dr. Roach, if you can keep more people in CKD level 3, I think you'll, instead of having them have to progress to 4 before they can get nutritional guidance and all of the other things, if you can keep them at 3, you won't have to have so many people in end-stage renal disease. So I noticed on your slide, everything starts at stage 4. I was at stage 3 for several years till I got an acute kidney injury. If you can keep people in 3, you won't need as many kidneys, you won't need as much dialysis.
I totally agree with you. We had to, just for logistical purposes, we started with 4 and 5. That's not to say that at some point in the future that we can't focus on 3. One of the big problems, though, is actually finding those people with 3. There's lots of people walking around that have kidney disease that don't know it. And so that's one of the challenges that we have as a healthcare system overall, have. It's hard to treat people when we don't know, and this is a silent disease, as a lot of people know. So, but thank you for the comment.
Okay, everyone, would you please thank our panelists? I think they did an excellent job in terms of sharing information. Moving right along, I'm getting the eye. Back on script. Well, I am the next moderator. Now I have the pleasure of introducing our next session that focuses on very important topics for patients, technology and advancements. Our next discussion is appropriately titled, Trending Today, Technology and Developments That Impact Your Care. And again, all of these, I want everyone to pay close attention because this is part of the strategy that's going to be used to address some of those goals that we talked about earlier. So, we're honored to have with us today Dr. Kenneth Newell with Emory University. He's going to discuss organ procurement and allocation. Dr. Reginald Situ with CareDx to discuss iBox and the use of artificial intelligence in transplantation. We have Mr. Joe Muldoon, CEO of Fast Biomedical, to discuss his company's development of a more precise and efficient way to quickly measure kidney function. And Eric Litjens with Hansa Biopharma to discuss their transplant initiative to unite patients online at a global level. And now, I will turn it over to Dr. Newell to get started.
Thank you, sir. Thank you very much. Well, thank you for including me in your meeting. I've been doing this so long, I've seen a real transformation where we used to speak for patients, then we kind of spoke to patients, and now hopefully we do better listening. I will also commend you on your 50th anniversary. I'm old enough that I can't really remember what I was doing when I was 50, but hopefully it was something positive. So these are simple disclosures, relationships I have with various companies. None of them affect this talk. I think that we need to kind of understand the framework for how we got to where we are today. So prior to 1968, concepts around brain death and organ donation were very hazy. They weren't codified, and so the Uniform Anatomical Gift Act was the first attempt at establishing a national transplant program. NOTA, or the National Organ Transplant Act, which we'll talk about in a moment, was enacted in 1984, and then we'll talk about the final rule, which is really now driving discussions about allocation. So who are the players? If you want to know who to talk to, who influences policy, who creates it, these are the groups that are most important. So transplantation falls under the Department of Health and Human Services, and within that, the division charged with direct oversight of transplant is Health Resources Services Administration, or HRSA. So HRSA oversees this, but they don't directly manage it. They issued a contract to UNOS, who actually oversees the operation of the organ procurement and transplant network. So UNOS is a group that's open to bids. I forget, somebody here could tell me when the last time it was open for bid. I think it was about 5 or 6 years ago, but the only group to ever hold this contract has been UNOS. So the National Organ Transplant Act was sponsored by Al Gore and Orrin Hatch. Prior to this, it was a bit the Wild West. There were people who were advertising in magazines that if you had kidney failure and you paid them a certain amount of money and you paid the broker a commission, they could get you a kidney. Not a very transparent or fair system. I'm old enough to remember when we started the hospital I trained at, you'd go around to the adjacent hospitals and work out an agreement with them if there was somebody who was thought to be brain dead and the family wanted to donate. They would just basically say, okay, here, go ahead, retrieve the organs and use them however you see best fit. Then that seemed unfair, so they created a waiting list, but they still had a system where the hospital got to keep one kidney and put it in whoever they thought was best. So obviously you can see how this goes wrong. So they said you can't sell organs. It mandated the establishment of an expert panel or a task force to provide advice about how to set this up. It authorized them to set up these organ procurement organizations and the OPTN, and importantly, it created the Scientific Registry of Transplant Recipients. So long before other areas of medicine began to collect, analyze, and report their results, the transplant community did that. And Richard actually serves as an advisor on a panel to that group. So I think that's a group of great importance. I seem to be going the wrong way here. So this is the current way organ allocation and distribution is set up. So the country's broken into 11 regions. I'm from Atlanta, so I'm in Region 3. You can see where you are. What you can't see in the other thing is there are these donation service areas or donor service areas. There are 58 of them, and they control policy at the local level, allocation. And the problem is there are 58 of them, and there are about 60, apologies to those of you who work for them, but there are about 60 different policies. The rules for how organs are procured, how they're shipped, who gets them, not who gets them, but it's highly variable. And so that's one thing that would help to standardize to make this more efficient. So now we come to the final rule. In 1998, Donna Shalala issued the original final rule, which was designed to distribute organs more equitably. We'll come to this, but there's a large disparities in who gets transplanted, and a lot of that has to do with geography. The implementation was delayed until 2000, in part because a number of states and universities sued the government, claiming that organs belonged to states or regions, and as it turns out, states can't sue the federal government. That was a fairly short suit. So what does the final rule intend? First of all, it says that you must use sound judgment in allocating kidneys. It says that you have to achieve the optimal use of the organs. You have to preserve the ability of the transplant center to decide whether or not to accept an offer. And Richard touched on this just a little bit. It's appropriate. There are organs that should not be transplanted. They might be appropriate for one recipient and not another. That's an important part of the medical decision making, but it's not very transparent while you're on the waiting list what's happening. And I think that's one thing that the field could really do to improve, so that you're more a partner in deciding what you would be comfortable with. You're supposed to avoid wasting organs. You wouldn't want to procure an organ and not be able to expeditiously place it, so it just the timeline on it expires. You don't want to perform futile transplants. Certainly no one in this room wants to receive a transplant that doesn't help them, especially if it could help somebody else. You want to promote access to transplant. That's something we have not done exceptionally well. And finally, you want to efficiently, and this will be important when we talk about the new allocation proposal out for comment, you want to make this efficient. You don't want to be, flying kidneys all over if you can just use it equally well in somebody equally deserving locally. And so this brings us to geographic disparities, and this is driving everything now, and there are more lawsuits. And so we'll see how this goes. But it says that your place of residence should not determine your access to a transplant. It also says things like you cannot propose a policy or enact a policy that decreases the total number of transplants performed. And you can imagine that in some cases, these aren't really aligned. Perhaps to me, if the very best recipient for a kidney procured in Honolulu is in Maine, that just may not be practical. And so these are not all always lined up, and I think that's where the debate comes in. So this is a talk that I gave with Alex Weissman to our fellows at a transplant meeting in Dallas in 2013. So at 2013, when we gave this talk, you basically got to the top of the list based on points. You got 1 point for every year you'd been active on the waiting list. You got 1 point for matching certain antigens, compatibility antigens. You got points if you were highly sensitized, meaning you had a lot of antibodies that prevented you from being compatible with most recipients. So, if you were only compatible with 1 in 10 recipients, you're disadvantaged compared to somebody who's compatible with 9 of 10. So I thought you should give points there. And then you got points if you were a former living kidney donor. We should honor those and reward those who have made an impressive sacrifice. Practically speaking, this unbalanced the system, though, because what it became is just the person who waited the longest got the kidney, whether they were the best for the kidney or not. And so there was that, and some of the HLA, those histocompatibility matching, I said, disadvantaged certain ethnic groups So they decide to rectify this. So this is driven by what they called, the original proposal was called life years following transplant. And this shows you that if you look at the panel to the right, and it shows you the bottom line, I don't have a pointer, maybe I do. Yeah, this bottom line here shows what your life expectancy on dialysis is, and this is transplant, and everything in between is life years gained. And it shows you for a 20 and a 50-year-old. Well, you can quickly look at that and tell that overall 20-year-olds benefit more from transplant because they have more life ahead of them. That's not surprising. So they came up with the idea where there was a mathematical formula to predict how long a kidney was likely to survive, and there was a mathematical formula to predict how many life years people would gain following the transplant. And they said, why don't we take the kidney that will last the longest and put it in the person who will live the longest? Kind of makes sense on some level. They also said there's a real injustice. If I sit on dialysis for 5 years before my nephrologist refers me, and then I go and I get listed, that's time 0. So if it takes me 5 years to get a transplant, I'll wait 10 years before I'm transplanted. Somebody else has a nephrologist who sends them before they're on dialysis. They wait 5 years, not fair. So they said, we're going to give you waiting time from when you first start dialysis or develop stage 5 CKD. So they were going to fix all those things. And this didn't fly at all. What is it? I'm not going to say AAKP, AARP, which I'm a proud member, said this is age discrimination. Because you can see here, what happens is you just shifted all the kidneys to younger people because you were predicted to add more years of life to the pool. And as somebody who's in their 60s, I suppose on some level, again, I accept that, but I don't want to be totally disadvantaged. So I'm going to skip some of these because I realize I don't have as much time. So they came up with several proposals. The first was national sharing. No matter where the kidney comes from, it goes to the best person in the country to maximize life years. Well, you would add 34,000 life years with that policy. But there's some discrimination there, there's some logistic problems. So they eventually came up with what they call longevity matching, and we'll come back to that. I'll skip that because I realize I don't have enough time. These are the factors that just go in case you're interested, into what predicts how long a kidney lasts. So these are donor factors, and then these are recipient factors. And one of those, if you'll be able to join me talking about preemptive transplant, one of the more important things is time on dialysis, a powerful predictor of survival following transplant. So what they ended up doing is they broke kidneys into the top 20% based on that formula, the bottom 15%, and kind of everything in between. And then that drives how it's allocated. So they did partially match longevity. So if it's the top 20% of kidneys, it goes to the top 20% of recipients. The other thing I'd point out is this bottom part here is what we call high KDPI kidneys. Those are the bottom 15% of kidneys that are transplanted, but are still transplanted. They still help people. For that, people signed a separate consent. And where that really makes sense is I age. You know, if somebody tells me I can wait 8 years and get a kidney that goes 20 years, but I'm 75 years old, that's not very helpful. I'd rather get a kidney, to Richard's point, that might go 3 or 4 or 5 years, but I can get it like soon because I need it now. And so that's kind of what this allocation system was designed. And this shows you here, even those, I'm pointing at a screen you guys can't see, that's not very helpful. Even here, this is the survival of the worst kidneys versus the best. It's still pretty darn good. So, and this is to the point of one of our previous speakers, this is the discard rate. So you can see, or the number of kidneys no one chooses to transplant. So at this higher thing, a lot of these kidneys can help people, but they're thrown away because we're afraid perhaps of hurting individual people. But this is where a conversation with patients matters. We don't all make the same decision. I need to know what your preferences are if we're going to be able to meet your needs. So I'm going to skip over that. This simply tells you, it's a complex slide, but it says waiting times are going up. Not shocking to any of you. This is, though, a slide that Alex made that we showed in 2013. And this is waiting time based on where you live in the country. So, oops, that didn't help me. So if you go back and look like here in kind of Kansas, the waiting time's really short, on average less than 19 months. Now this is data that's a little old, like about 2 decades old. But you can see already in California, the wait time can't be calculated. They don't transplant enough people to know how long the average patient waits. And people say, why is that fair? That seems unfair. Geography is determining your ability to be transplanted. Interestingly, again, I'm in Georgia. We have medium waiting time. Right next door is Mississippi, is Alabama, that has one of the longest waiting times. We get a ton of people who cross the state line to get transplanted because we can transplant them faster. Why is that? Doesn't seem reasonable. I'm going to skip this. This points out that the transplant rate's different and that the mortality on the wait list is different. So again, emphasizing geographic disparities. So several groups here, and I won't read all this, but have said that donated organs are a national resource. It doesn't belong to the state of Georgia. It doesn't belong to the city of Atlanta. It doesn't belong to Emory University. It's a national resource. So that's a fundamental underpinning of policy. So the new kidney allocation system was created by the OPTN Kidney Transplant Committee. It's a group charged to this. It's out for public policy. So if you want to have your voice heard, you can simply log on, you can read the policy, and you can comment on whether you like it, what parts of it you'd like or don't like. The aim is to reduce geographic disparities by changing, not allocation. Kidneys will still be allocated roughly the same, but they're changing geographically. They're no longer, like where I live, there's an OPO called Lifelink of Georgia, and kidneys basically stay in Georgia. If you live in Chattanooga and there's a donor in the north part of Georgia, you're not really competitive for that kidney, not as much as somebody who lives in Atlanta, even further away. This just is some modeling done by UNOS that shows that the most powerful predictor of disparities in access to transplantation is what donor service area you're in. Now, you can make the argument that some donor service areas don't do as well recovering organs from willing deceased donors. That might be part of it, but part of it is just the ability or the frequency of donors. And this just shows the same thing here. These are all the DSAs, and it shows a huge variability in your likelihood of being transplanted. So the details, and I'm going to skip right to the picture. So what they said is they're going to, if there's a donor in this hospital, that's somewhere in Kansas, I believe, geography not being my strong suit, they draw a circle that's 500 nautical miles around it. And everybody in that circle has the chance to get that. Then it goes back to the same point system I told you about before. They also came up with a thing which they called proximity rating. So you can get between 1 and 4 points. So if you happen to be right in the same hospital as that donor, and that's where you're going to get your transplant done, you get 4 points. The further you go to the outside of the circle, the fewer points you get until you hit 0 on that 500-mile rim. If no one in that 500-mile rim or circle can use it, then you go outside another 2,500 miles. And there you get 8 points. So if you're at 501 miles, you get 8 points, and that goes down to 0 points if you're at 2,500 miles. But again, those points don't compete. It's in the circle mostly first. And this just shows that. They considered circles of other sizes, and that was the one that was thought to optimize transplants while still minimizing flying organs all over. In truth, if you have two people who are equivalent in terms of the benefit they would receive, and one's 50 miles away and one's 500 miles, you don't want planes flying organs all over. You don't want donor teams flying all over if you can avoid it. So I don't have time to go through this, but this is the allocation algorithm, and it's pretty much the same one that they enacted in 2014. So I'm going to skip that. So as in all things, there are people who gain and lose. So the group that gains is pediatric recipients, former living donors, I think I left off, African Americans, Latino ethnicity, women, people with longer waiting time, and more sensitized patients. Who loses? People over 50, and particularly those over 65, those living in rural areas, and those predicted to have the best survival following transplant, kind of paradoxical. That said, I'm pointing again to the wrong screen. These are all small changes. They're not big changes. So I'm going to be 65 in a couple of years. It's not that I'm not going to get a transplant. It goes down a little bit, not a lot. So for those of you approaching my age, don't worry. So these are the questions that specifically the Kidney Committee wants to hear. And I don't have time to read them all, but you can go online and pull this up. It's a very transparent process. But they want to say, should the circle be bigger? Should it be smaller? Should we give proximity points? They'll ask questions like that. And I'm going to finish with my thoughts. And I don't speak for anyone besides myself, and probably, in fact, no one agrees with me, but these are my ideas. So change is going to happen. The field has spent a lot of time trying to stop HRSA from enacting a change, and it's going to happen. They've interpreted the law saying there are geographic disparities and we need to correct those. I think that any proposal to me would be unacceptable if it decreases the number of transplants we do. And I think we need to have a proposal that maximizes the benefit that each kidney confers to people. I think other important things are that you make it, if you will, as inexpensive as you can. So you're not flying organs all over, you're not flying surgeons all over. Each year, surgeons are hurt and in some cases killed flying to do things, into small cities and airplanes. I think that's a silly thing, perhaps worse than silly. And then I'd say, the real problem for me with this is that we look at people who get on the list. I'm from Georgia. Georgia has some of the most disadvantaged people around. Most of our patients never get referred. They don't get evaluated. They don't get listed. There's data to show this very clearly. We don't speak for them because they don't count. If you don't get on the list, they're only looking at disparities of listed patients. So I think you should look at disparities based on the people who are eligible and who would benefit from a transplant. So that's my only knock against this policy. And so I'll stop there and apologize if I ran over. Thank you.
Thank you.
Hi, my name is Red Cedar. I'm the president and CBO of CareDx. I'd like to thank Richard and the AAKP for the honour and privilege of being here today. It's a really important meeting. I think following on from Dr. Newell, who is one of the leading transplant surgeons in the United States, and the fact he is here tells us how important and critical this meeting is for him. And I think what I want to do today is share what we've been doing as an organisation and company to sort of contribute to the field of transplantation, particularly with technology. Before I sort of go further, it's always important to know your audience, and I think I know most of the audience here in terms of your backgrounds, because I did ask a bit about that, but just to help me out, how many transplant recipients do we have in the room? If you just put your hands up. Okay, keep your hands up, thank you. And do we have any living donors, transplant living donors? Okay. Do we have, and who's part of the healthcare profession here as well? Okay, great, fantastic. I want to thank each and every one of you. And the reason I say that is because we, CareDx, exist as a company, and we wake up every day because of you. You've given us a sense of purpose. You've given us a sense of mission. I've only been in the company for about 12 months, but within that time, it has been the most incredible experience in my personal professional career. I've never been with a company that's been so patient-centric. We're 100% dedicated to transplantation, and every single moment in the company, we ask and challenge ourselves, what more can we do for the transplant patient? And I'll go through some of the presentation, but one thing that made it very real for me is my aunt who lives in Virginia. She's actually waiting for a third kidney transplant. But, for her, she doesn't know if she'll get that third. She's in that category that Dr. Newell mentioned, past the age of 65. But as I talked to her, I shared what we did as a company and organization to provide some hope, and also at the same time to know that what our mission is for future, transplant recipients in the future, because for us, we want to improve that outcome. We actually went to a board meeting earlier on this year, and we've always talked about how do we improve that outcome for the patient. And so for the first time, we said, let's put a challenge out to us as an organization. Let's see how we can improve organ outcomes or survival by 30%. And that's a really bold statement for a company to try to do. And I share that with you because, again, we have a mission, right? And I think that's important because if you don't have that sense of purpose, why are you part of an organization? And I think each and every one of you provide that inspiration for us as a company to keep on doing what we do every day. At every single patient meeting, at every single staff meeting we have, in every single town hall, which is once a month, we have a patient that comes out and talks to us. And the reason we do that is to remind every single new employee and every current employee of why we do what we do. And I don't know if every company does that, but I think it's important when you're 100% dedicated to a field, when you're 100% dedicated to transplantation, that everyone understands what our core mission and what we want to do as an organization. So I will go through some of the slides, but I did want to share that up front because I think it's really important to know what makes us tick. And again, we want to be your partner. We want to serve you. We want to serve the patients, but we also know we have to serve the Dr. Newells, the Emerys of the world. We also need to partner with organizations such as AAKP, which we're a proud sponsor. I mean, it's really important for us to be part of this broader ecosystem, and that's sort of our vision. But once again, our mission or the challenge for us is how do we, bring innovation, and how do we bring solutions for each and every one of you out there? It's also real. As you go through this, these are real patient photos as well. So I see many folks in the room that may know CareDx, but I just wanted to remind some of those who may not know us. We've been around for 20 years, which, as we look at AAKP celebrating their 50th anniversary, not quite as long as the AAKP, but certainly 20 years is still a long time. And I think for us, what's been the foundation of us as a company is science and technology, and I'll go through a bit of that and why it's driven us as an organization. But again, I want to reinforce what's critical to us is what we can do for patients. So I'd ask everyone now to think of what you're doing in 1999. Okay. Richard, what were you doing in 1999? Do you remember?
Well, I wasn't on dialysis.
Okay, weren't on dialysis. Joe, what were you doing 20 years ago?
Working hard.
Okay, all right. Dr. Newell, Dr. Newell, you talked about sort of can't remembering 50 years ago, but I think you can probably remember 20 years ago. What were you doing back then? No. Okay, all right. Okay, same as now. What I can tell you, back 20 years ago, there were a group of researchers who put together this company and who were working really hard to say, how can we make improvements in the field of transplantation? And it took them a long time, but they finally came up with the first innovation in gene expression profiling for heart transplant patients, a test called ALMAP, and some of you may or may not have heard of that. But it was a long time in the making. That then took us to 2014. And I mentioned that because I had dinner last night, the privilege of having dinner last night with Dr. Newell, and he was president of the American Society of Transplantation. And I asked him, what was he thinking 5 years ago? And I'll remind him because he may or may not remember, but 5 years ago, he was bemoaning that the end of innovation and the end of investment in transplantation. And this is coming from the head of AST. And to be candid, that was true. Companies were leaving, most of the major pharmaceutical companies. MedTech was leaving the sector. Diagnostics wasn't, a fully fledged sector. And I think who was helping the transplant field? Who was helping each and every one of you out there thinking about not only your future, but the future generations of transplant recipients? And I'm proud to say to be part of CareDx because five years ago, we had a group at the company who had the vision and the mission to say, this is our purpose. And they started then saying, what will we do next in this field? And they then invested in this new technology called cell-free DNA, and within a short period of 3 years, were able to build the next level of technology for patients with kidney transplants. And then they bought a pre-transplant business because at that time, people weren't investing in transplantation, right? So we had a vision. We were a US company at that time with one offering. And in the period of 5 years, we became a global organization, not only with one offering, but with multiple offerings, both pre and post-transplant. And we developed what we call a pipeline built on technology. And every single cent we have that goes into research development, you can talk about other companies, but every single cent that comes in our organization goes in the field of transplantation. And that's really important because last year we had 3 R&D programs. This year we have 13. And we continue to invest because we believe in what we can do as a company in the field of transplantation. So again, this is the board slide that we presented to our board of directors, where we threw out the challenge to ourselves as a company. And again, I would always challenge yourselves, what's something tangible and meaningful that you can do in your life that leaves a legacy? And I think for me and my team, this is the challenge we place out to ourselves. Can we, when we reflect back on our careers when we finish, would we have achieved this 30% outcome? Can I go back to my aunt and say to her, this is a vision that we had and we delivered on that by the time I finish with my professional career? And I think there are three areas that we need to think about. One is immunomodulation, where I think there's often over-immunosuppression, sometimes there's under-immunosuppression, but it's a fine balance. And how do you get that right? I think the other area is compliance and adherence. I think my aunt would be the first to tell you she wasn't very, very compliant after being on, having been a recipient for many years. I think she then sort of took it a bit for granted. But I think the compliance and adherence is really important. And I think having visited, more than 100 centres, and our team has been to all the centres, is there is a huge variation in every single transplant centre. But what would help, and not being disrespectful to any of the centres, is I think that helps if there's some standardisation in process. So these are three areas that we're looking as an organisation to see how can we improve outcomes. So I shared this slide because given that challenge we had and what we presented to the board, how do we now deliver on that mission? And I think one area we've made a serious investment and a focus is on artificial intelligence, and also now looking at a digital sort of platform, if we can build that. And how do we monitor patient results longitudinally over a longer period, and then see how we can then provide offerings that can sort of help patients during this time. One thing I'm going to share, which is sort of the leading sort of artificial intelligence within the field of transplantation, is called the iBox, and that's come out of a group from Paris, and it covers 10,000 patients, and it's 10 years of data, and it captures all the data points because it's a national system which on these patients, and then you can look at outcomes, prognostics. And so we have those rights for the US, and we're now incorporating that into our testing. So again, this is just some of the commitment we have in sort of our products that are available. And I mention this because, not because to show you what the offerings are, but because there are three areas. We have the testing services, we have products, but we're really investing now in digital, and I think that's really important. You'll often hear companies talk about artificial intelligence. You'll often hear about companies use these fancy words, but I think when you use that word, you want to show a commitment. We've, in the last 4 months, for example, acquired 2 companies, one as recent as last week, to invest within this field of artificial intelligence. We're actually actively hiring to build out our group as well. One thing that I do want to share, which I think is important for any company, is are you validated by good science, and do you invest in what you sort of believe in? And one thing that's fairly unusual for diagnostics, not so much in the RX world where I've come from, is do you do studies, and do you do large studies, and do you do multi-center studies? And that's really important, because in the field of diagnostics, often tests are not fully validated in patients. Often tests aren't done at multiple centers, but we have taken very much a approach where we believe that the more validation, the better. And that's why we've invested a lot of time and effort in doing multiple studies over multiple centers over multiple years. And that's really important for us as an organization, to be validated by good science. So this is sort of what I've been showing in a snapshot. If you look at on the left-hand side with AlloMap and AlloSure, what we call our genomic biomarkers, this is something that we've left our legacy. We're the first and only test in gene expression profiling in the field of transplantation. We're the first and only test with cell-free DNA in the field of transplantation. And these tests have created a market. They've helped create an opportunity to improve patient outcomes. And as a result of that, others are actually coming into the space, which we encourage. I think that's really exciting. But for us, we've actually moved on. We said it's great. We're innovators, right? We're not a me too. We believe investing in innovation and leading. So we've done that. And what we've done now is, how do we do what's called multimodality testing? So looking at how you improve organ outcomes, but at the same time using more than one test, and doing them in large sort of trials and studies to show that they work. So that's where we are today. And then when we're moving in terms of the future, so when I talk to you here next year, I talk to you in 2 years' time, I'll talk to you in 5 years' time, we're going to get to this field of artificial intelligence to make sure that we can give you even more information about your precious organ that you've received. So for us, it's really important as an organization. And within 10 years' time, or 20 years' time, we'll come with even further improvements. So again, just to show you what we're calling, and if you see any of your physicians or your centers who, if you happen to be a kidney recipient, we also have the same with heart, but I thought I'd just share it for kidney. We have a opportunity offering called Kidney Care, and it combines a measure of graft injury. So if there's actually some rejection or if there's some injury taking place, then we'll be able to pick that up. At the same time, we have a test which measures the immune system and can tell you if something's happening or not. And thirdly, we have this real artificial intelligence, real-time learning based on 10,000 patients. So I want to end off there because I do think investing in technology is important. And I think over the last 5 years, we've brought the only technological innovation in the field of transplantation, at least in terms of diagnostics. We've now moved on from that because we want to do more. We're investing in the next field, which is artificial intelligence, and we're combining that with the multiple technologies we've brought called through Kidney Care. And the reason we do this is because each and every one of you out there motivate us, and you keep us going. So all I can ask is that, know that there's a company that's 100% dedicated to transplantation, that any of our investments is 100% back into R&D, into transplant programs, and that our mission and our purpose is to serve you and to make sure you get the best transplant outcomes possible. Thank you again.
Good morning. My name's Joe Muldoon. I work for a company called Fast Biomedical. I want to thank Paul and Richard and Diana for inviting us here today. It's a thrill. I've been coming to these for a while. What I like in the morning session so far is each time there's one of these meetings, I find that the candor of the dialogue keeps increasing, and I think that's kind of a healthy progression. Sorry, Richard, but I'm going to take a page out of your script. I'm going to go off script a little bit. So here's what I heard this morning. We need to get more organs in the pool and transplant. I would humbly submit that our technology can move the needle on that. We need to diagnose kidney disease earlier and start treating it earlier. I would humbly submit our technology can move the needle on that. I hope Dr. Mudrow of DOD is still in the audience, because if you're looking for gaps in the system, I've got one for you. I hope Dr. Kimmel of NIDDK is still in the audience. NIH and NIDDK have been incredibly supportive of us. Without their support, we would not be here today. And I want to thank AAKP. I first learned of AAKP, I sat on the board of Kidney Health Initiative, and I'd tell them I was their token entrepreneur. And they're talking about patients, patient engagement, we're going to have patients on the board, we're going to have patient advocacy groups, and I was arrogant enough at the time to think, well, that's a good idea, but I'm pretty tuned in to the patient experience. I was wrong. I learned so much more than I thought I was capable of learning in that area, and it's changed me, and I thank you for that opportunity. All right, what are we working on? We're based in Indiana. We're right over the border from Indianapolis. We're privately held. We're advancing technologies that were actually came out of Indiana University School of Medicine, which is the largest school of medicine in the United States. I'm not sure how that font got so small, but it did. What we're working on is first-in-class technology to measure kidney function and blood volume. You might be surprised today that that does not exist in medicine. Today you can decide whether you want an accurate measurement or you want a quick and easy measurement, and you get to pick one. It moves us past the trailing indicators that we're using today that have a lot of limitations, and I'll show you those in a minute. So currently we have estimates of kidney function, eGFR, you've probably heard that, and we're tracking your serum creatinine and putting it through a formula. On the blood volume side, we look at a whole host of things to try and assess your fluid status. We meet the requirements for an FDA expedited review, which is pretty rare, and we've enjoyed substantial NIH support. This is an investigational product not yet approved for human use. So the opportunity on the kidney function side is the problem is we catch renal dysfunction too late, making it nearly impossible to time the therapy so it actually works. We underdose and overdose renally cleared and renally toxic drugs because we don't know what your renal clearance is in real time. Clinical trials for renal therapies are very difficult to conduct because the accepted endpoints are death and dialysis, and those are very difficult endpoints to design a trial around. We think we can impact acute kidney injury patients, cardiorenal, drug dosing, particularly antibiotics in the critical care ward and chemotherapy agents, and chronic kidney disease patients. This is a slide on eGFR. So the data proves this overwhelmingly, not only our data, but previous data, that serum creatinine is plus or minus 30% from what your actual kidney function is. And the reason is because serum creatinine is a very slow to rise, very unresponsive marker. So in an acute kidney injury patient where their function drops rapidly, this is actually what their serum creatinine will do. It will take days for it to rise, even outside a normal range. So when you take that serum creatinine and put it into the CKD epi formula to calculate an estimated GFR, it will show a similar slope, a slow decline in the function. Here's what's actually happening with the measured GFR. That patient's hitting a wall and their function's dropping. And you can see that we don't know for another 1 to 2 days to get involved. Here's some data on the CKD epi formula that calculates your estimated GFR, and these are comparisons of an estimated GFR versus a measured GFR, as you can see over a wide variety of patients. Here are our observations. That's a really wide spread around the mean. So if you realize that your estimate can be plus or minus 30% of what your actual is, that shows you can get an estimated GFR of 50, and it means that your measured GFR could actually be a 35, which is disease, severe disease, or a 65, stage 2 CKD. So when we talk about, understanding what stage you are in and, what questions to ask, the reality is we really don't have a standard of care tool where we're capable of doing that today. There's a big difference between a 35 and a 65. So our observation is eGFR is accurate across a population, but we're more concerned about it being accurate on an individual patient level. And for that to happen, we really need measured kidney function. That's what's going to be required to move kidney disease into the precision medicine realm. On the blood volume side, this is a page of some primary market research we did in critical care, and it showed that critical care physicians would find a direct and accurate measurement of blood volume helpful. 92% of them would, and they wanted to use it on the vast majority of their patients. This is kind of believed to be one of the last frontiers in critical care medicine, is really being able to optimize managing a patient's fluid level, which we struggle with today. What do they do to determine your blood volume level? There really is no standard of care measurement. They look at a whole host of things and aggregate them together to give the best estimate, but they're frustrated with what they have. The experts have really kind of coalesced around what we need to move these fields forward, or direct and accurate measurements of both kidney function and blood volume. And we can do it. So we have a device. It sits in the lab. It works in concert with an injectable that we developed. The injectable is an inert fluorescent compound. We give patients a very small dose of it, 3 milliliters in solution, and then we take timed blood samples to do our calculations. Blood volume, we really only need one blood sample, a microliter at 15 minutes. For kidney function, we need 2 more blood samples over about 180 minutes. So turnaround time to the physician is between 45 minutes for blood volume up to 210 minutes for kidney function. Most important slide in the deck, so how might it impact patients? One is, for the first time, it'll give us the ability to measure renal reserve. And I don't know if you're familiar with the concept of renal reserve, but some leading nephrologists believe that renal reserve is as, or maybe even more important than what your kidney function is, because it tells you what your kidney function could be. So when it gets stimulated, when it gets challenged, what can it perform to? We've got a technology that can measure renal reserve. We think eventually it could be a better endpoint for clinical trials. How well did this therapy resuscitate function? We think clearly it can improve the detection of early onset to not only treat patients, but to stage them for clinical trials, and can allow more precise dosing of renally cleared or renally toxic drugs. For end-stage renal disease, blood volume would be critical to establishing dry weight, so we can get the fluid management correct. I just read KHI did a supplement to their renal replacement therapy where they talk about that, here's all the ways we're trying to assess and titrate to a patient's fluid level, and we struggle to do it, and one of the best solutions would be a direct measurement of blood volume that was clinically actionable. We think it could actually delay, possibly, end-stage renal disease by better management of chronic kidney disease. For transplant patients, better evaluation of living donors to increase the number of organs for candidates in the pool. We did a publication, and our phone started ringing with transplant physicians that said, if we had a way to precisely measure donors, both cadaver and living, we could make better decisions on that harvest. And then after we transplanted it, we could more quickly and accurately see how's it functioning, and then also dial in the dosing of the immunosuppressants. We get the dosing too low, the body kills the organ. We get it too high, have bad side effects. Clinical history. So today we've completed 4 human trials. We have 147 patients that we've tested on, many of them repeat measurements. We're through phase 2. We've done our trials in Germany and in the U.S., in Alabama and Texas. We've tested healthy patients all the way up through chronic kidney disease stage 4, and we just completed a trial in heart failure patients that I'll tell you about in a minute, which we're very excited about. What we've learned is our injectable marker is well tolerated. There are no SAEs that were reported. We have an extremely accurate, repeatable, and sensitive measurement, and we've hit our primary and secondary endpoints in these trials. So now this data is getting published. You might have seen this one before. This came out in JASN. JASN's the #1 impact factor journal in nephrology. We compared ourselves to iohexol clearance. Iohexol clearance is an accurate way to measure kidney function. It's not clinically viable because it's too cumbersome and it takes too long to get the results. But we compared to it, and across all levels of function, we had a 0.996 correlation. So we're as accurate to the gold standard as the gold standard is to itself. On the volume side, we got this published in Cardiorenal. We took patients at all different levels. We gave them a volume challenge. We gave them fluid, and then we showed that we could precisely measure the change in their intravascular volume, kind of speaking to the precision of our ability to not only measure volume, but more importantly, measure changes in volume. And then we showed also in that same publication that it was highly reproducible day to day over different patients. The slide that we're probably most excited about is we just completed a trial in heart failure in Berlin. As our data was coming out, we were getting many opportunities to join trials. We joined this one in Charité Hospital Network. We dosed 50 patients. We compared our measurements to what clinicians use as standard of care to assess volume status and kidney function. It's an observational trial, so the clinician was blinded to our data, and then it's unveiled at the end. That data is starting to roll in now, and we'll spend this quarter and next quarter analyzing it. It goes to an independent data adjudication committee next quarter, and we think we'll get a dramatic publication out of it in 2020. I can't talk to specifics because we need to keep it confidential so it can get published, but I can tell you generally we saw virtually no correlation between measured GFR and estimated GFR in these patients. And we did not, the trend from day 1 to day 3 treatment day 3 of treatment in eGFR was not predictive of the trend in what was actually happening with their GFR. And we saw a similar non-correlation with the actual blood volume measurement and the clinician's assessment of where they were volume-wise. So we think there's the potential here for really strong clinical utility data. Next steps, we've received a dozen clinical trial opportunities in the last 4 weeks. We're really trying to assess them and see which ones make sense, which ones would we want to do. They're in testing renal reserve, doing more heart failure. We were approached on an oncology trial. We've been approached by 2 big pharma companies about doing a renal drug trial with them. We'll assess that. We'll try and figure out what's the right thing to do for patients and for the business. To get a regulatory approval, we believe we're 1 pivotal trial away from approval. We've shared our phase 2 results with both FDA and EMA in Europe, and we believe we can get a harmonized trial where we do 1 trial in both geographies and get clearance in both. And we'll need to continue to demonstrate safety in these populations, and we're finalizing our endpoints right now. From starting that exercise to finishing it, that's a little bit less than a 3-year time horizon. We've benefited, my last slide, from really the best of the best in nephrology, critical care, heart failure, and cardiorenal. Really wonderful physicians that care about changing the status quo that have guided us along the way. In summary, moving from estimates to measurements of kidney function is an important step in bringing precision medicine to kidney disease. Accurate and timely kidney function and blood volume measurements could impact renal patients in a multitude of ways, and these technologies are in late clinical stage development now, so help is on the way. Thank you.
So good morning, my name is Eric Litjens. I work for a company called Hansa Biopharma. Hansa Biopharma is a company based in Sweden. We have 60 people worldwide, and today I'm here with one of my colleagues. So that means that 1/30 of the company is present here today. And I wanted to congratulate the AAKP both with their 50th anniversary, but also with their 44th National Patient Meeting, which was set off to a great start this morning. And we're thank you. And I'm pleased today that I can talk about transplant, and I think the name is a little bit of a giveaway. So if we can go to the next, I actually have to go to the next slide. So I first wanted to start a little bit by explaining what transplant actually is and then go a little bit more into detail. So transplant is a plan for transplantation to set you up the best way for transplantation. So the promise behind the plan is that it serves as a constant companion to help you guide through every step of your journey to transplantation and beyond. And the beyond is defined, or we define it as to get to a point where you have a stable graft function for as long as possible. So the program doesn't end with the transplantation, it goes much further on for years after that. So if we look at it in short, so there are 3 different parts, but they're all interconnected, but they're also fairly separate. So the first bit is a dedicated online transplant community, and that's actually a learning or resource center online where a lot of the available content that is already on the internet is being pulled in a curated and in an organized way to give you the best that is available, to help you with every step on the way to going from where you are today to transplant and to that point beyond. The second bit is actually 2 separate bits. So it's a patient registry, but also with a clinical practice registry tied into each other. And when I started my career, I started to work for a company called Genzyme. We were very proud of the registries that we had. I think the only thing that we were very sad about was that the fact that they were not patient-centric. So in this case, we wanted to build patient registries that started with you as a patient. So you're in control over your own data, what you contribute, and how you want to progress, and you can opt out any given moment. One of the reasons that you can do that is we follow European GDPR. We're a European-based company, so we're required to do that, and that gives you the right to be forgotten. Gives you the right that we tell you exactly what we collect, how we collect it, and what we're going to collect it for. So that puts you in control and in charge over your own data. So then the next step, for those who are willing to do it, they can their physician or their hospital to bring their clinical data online. So the electronic medical record can be pulled in automatically. We specify exactly what data that we're going to pull in. So we marry both the patient-reported outcomes that are in the patient registry with the clinical practice registry, and that's something that we also do in collaboration with larger medical organizations. And I just wanted to go back a little bit to the first bit, so the online community portal, because you could argue that there's a lot of content created by patient organizations like AAKP, so why do it? Why create a specific resource for transplantation? So actually we came to this point after discussions with the patient organizations, amongst them AAKP, that we wanted to create something that's really specific for transplant. Because a lot of the content is done by the patient organization and is on dialysis and everything related to that, and there's also a part on transplant. But we wanted to bring all of that together in one focal point in a very structured way. So transplant is designed to be your guide to reliable, relevant, and meaningful information, always with you in mind. So if we go back in time, why did we want to do this? So a year ago, we started to think of two things. So we wanted to do a patient support program in a specific way, and that was after discussions with the patient organizations, after doing patient market research, and talking to individuals to have something really that makes you help plan for transplant, no matter what your starting point is. But we also had the thinking about, we wanted to collect meaningful real-world evidence. So we wanted to be able to provide an opportunity for patients in an identified way to talk to us about what their quality of life was, the issues that they run into, and we wanted to collect that in a meaningful way. But we also wanted to have the opportunity to pull in the clinical data without knowing who that clinical data belongs to, and then marry it up, so that we could create something that the patient organizations would have insight in, the patients who contribute, also physician organizations who participate in the program, and often these real-world evidence packages are being requested by agencies like the Food and Drug Administration and the European Medicine Agency, and also reimbursement authorities. So we wanted to provide open and clear data of that we collect in a specific way around transplant and the journey to transplant. So for the program, we defined 4 goals. To help eligible kidney transplant candidates overcome barriers to transplantation, to increase the number of people who are eligible for transplantation by actually getting over those barriers, to help increase the number of available donor kidneys to meet the growing needs of end-stage renal disease patients. And one way of doing that is to actually build in a living donor registry within what we are trying to create. So more insight on living donation, but also helping with resources that for people that can think about donation. So this is a global program. In Europe, in a lot of countries, you have an opt-out donation system. And we just wanted to provide also information for people who are thinking of opting out or opting in, actually, to stay within the opt-in system so that they know what actually happens to the organs that they're going to donate after they die. And the last and very important bit is to empower and enable more patients with end-stage renal disease to choose for transplantation, because I think it is a choice that you have to willingly take. So, as I said, transplant, the name gives it away a little bit. I think you all guessed already that it was an acronym, and it stands for Plan, Learn, Achieve, and Network. So what does plan mean? So it's planning ahead so that you are ready by the time that the kidney becomes available for you. And I think you can never start planning too early in life for anything, but I think especially for if you have kidney disease, at what stage you are, you can already start thinking of how that future is going to look like. And then learn about your disease and learn about transplant in every possible way so that you can have an active role and can participate in your own treatment. And then achieving, of course, is about making the kidney transplant happen. But that can be quite some time out. So if a goal is far out, it can often be difficult to stay motivated and focused. So within the program, we want to give you the tools so that you can stay on target for as long as you need to be on target. And then the last bit is network. I think it's easy to understand that also in the case of a transplant, it really requires a village and maybe even a little bit more than a village. So you want to connect to your peers, you want to be able to connect to advocates, to healthcare providers, so that you have a really good foundation of support for your transplant. So what are we aiming to deliver? So we're trying to provide turnkey access, resources that can help you stay on track for transplant and cope with unexpected changes, to keep you informed about managing your disease and the transplant journey, to stay in charge, and to provide post-transplant support for the days and the months and the years ahead. And what we understand from market research, but also from the individual conversations that we have, that specifically the 6 months directly after transplant can be challenging, and you would like to have as much support and as much things to know during that period. So I just wanted to go step back a little bit about the data and the analytics, because they are a part of transplant. So there we have the 3 distinct parts: the community center, the patient registry, and the clinical registry. So what are we currently thinking of collecting in those things? Now, maybe I should have told that a little bit earlier. Transplant is still in development. And one of the reasons why we wanted to be here today and to talk about it is because we have a booth in the exhibition hall, and we are all invited to provide us with the things that you would like to see in a program like that, and also to talk about your concerns. Because we will collect data, and as I said, we will have to stick to HIPAA and to GDPR and a few other things, and we want to be absolutely transparent what we collect, why we collect it for, how long it will be used, and that we're not going to sell it. I think that's a very important point. So there's things that we look at in the community center, because also we want to provide you with the best experience. So we in essence, would like to know a little bit about you, to give you a journey within the portal, that you get the information that you're looking for. You can always look for other information, but it's just easier if it's delivered to what you're looking for. Then the same for the patient registry, and the same for the clinical registry. So in the clinical registry, there will be, so you would have to opt in and provide information that we can pull in certain parts of your electronic medical record, for instance, your clinical data and lab values, so that they are aggregated in a bigger data set. And in order to make that meaningful, you would like to know the age and the gender and where people come from. It's a global project, so we would like to see also for the reasons that we work with the physician organizations, how that actually all aligns. So this is my last slide, so I wanted to stay a little bit within the time allocated. So we do this with transplant and end-stage renal disease specialists, the major transplant organizations, we will cooperate with them, patient advocacy groups like AAKP, and industry leaders. So it's by design, we are not going to be the only company in this. But I think there's one major stakeholder absent from the slide and actually looking at it. It's all about you. And you are an important part of this, your contributors or potential contributors in this program, and also the information that would come out of it would go back to you. So that's my last slide. Thank you.
Okay, do we have time for a few questions? My timekeeper? Yes. Questions?
I have a question, especially for Dr. Newell. If you can help me understand a little bit more in terms of putting together the rules. A lot of organs don't even make it to transplant because of rules, other rules that are written about measurement of success of the transplant. How can that be coordinated in with this change in geography and all of that, so that we actually have use of all the organs that are available and aren't wasting ones that could be used for people who maybe just need something that's a transition until more research is done and we have more success and so on. It's very frustrating.
Richard, could you, where I'm sitting, I'm having a hard time catching all that. Could you, it's just I get an echo. I'm understanding a bit about success and things that limit patients from the access, or from access.
More about the complication of organs that are being wasted because they're not going to, quote, meet the measurement standards for a year, the rules that are written for that, for successful, but that needs to be coordinated with your, it's great to try and get more people on the list and get them more into it, but if we don't have the organs for them, you need to coordinate from my perspective. Can you help me understand that?
Well, and so I think I heard it more clearly that time, and you're talking about organs that aren't utilized that could help people because of the current definition of success and the kind of risk-averse nature of our field. So the penalties to institutions are huge if you fail to meet these definitions of success. And so people tend to shy away from things that they think will lower their success rate, even if it's not, and I hate to say this, but sometimes it's in the best interest of the patient to go ahead, but a patient's deemed too risky, and currently the way success is in effect decided is 1 year survival of the patient and the graft. And Richard was part of a meeting that we convened where we started exploring, that's a terrible definition. No one here wants 1 year success. We want longer term success. We want it to be meaningful. We want quality of life to be improved. We don't want to bankrupt families. And so we need a different definition of success. There will always be organs that we think maybe aren't ideal for one person, and the problem is to understand who they do work for, and that requires a degree of conversation between patients and the transplant centers that currently doesn't exist. Pretty much people get on the list, and they just sit there, and Richard might say, I'm totally fine accepting that. If it gives me 3 years of better life, I'm good with that. Reg might say, you know what, I want to wait. If I'm not getting 10 years of better life, I don't want to go through the surgery. And we don't know that. Currently, there's no way in our system to really understand that. So I think and that may change over time. I may see you and you may say, I'm doing fine on dialysis, I want to wait. And as time goes by and you're doing less well and feeling less healthy, you may change your mind. We don't communicate those things. And so maybe the tool you're talking about, the transplant tool, would be a way to communicate better, but all patients make different decisions, and we need to understand rather than kind of saying, we think the generic patient wants this. And if we understood that, and we felt that you were comfortable, then I think we'd feel comfortable using some of the organs that currently aren't used.
But it has to do with the rule also, because that the physicians lose confidence in using those organs because the rule is written that they have to be successful.
Well, and that's what I started to say. So we need to and that's a bigger conversation that we can have here, but actually some of you in this room may have contributed. Richard distributed for us. For the first time ever, we asked patients, what does a successful transplant mean to you? Currently, success is driven by people who do math and kind of decided, physicians, professionals, but we actually asked Richard to distribute to the membership, I think, what looks like success for you? Because there'll always be some definition. Transplant will never be unregulated. There'll always be people saying, are you doing the right thing? But we need to have a definition of success that's meaningful to patients and the society. And right now, we don't have that. So until we have that, we're kind of stuck where we are, because if the program is shut down, then that program doesn't help anybody.
Yeah, just add, in recent papers, talking if you use some of the European criteria, and would there be a difference in usage in kidneys in the United States? And I think there'll be several thousand, about 10 to 15%, which would be utilized under that sort of different criteria. I think the other thing that, just to reinforce Dr. Newell, is sort of reflecting where there's a 12-month sort of what is the graft success rate, which is how centers are currently measured. I do think that will be revisited probably at some point. I imagine, patient groups here have a powerful voice, and I think you've seen that even more recently, but how you define success and maybe contribute to that could be fairly important. From our side as an organization, when we look at, for example, the artificial intelligence, the iBox, we have all this data from cohorts overseas, and so we look at outcomes not just at the 12 months, we actually are looking at it 3 years, 5 years, and 7 years, and that's sort of data that's been validated. There's an article coming out on that from the group to develop it. So I do think outcome measures beyond that period is sort of more important success, but I do think at the moment there is a setup that defines it, and that's the current environment.
Okay, next question, but just so you know, that is part of what we're working on, and we will be involved in that discussion. And that's, Ken mentioned it, they have a set of rules to follow, and we can have some impact on those rules because they ultimately impact us. Yes, sir.
One of the important things in the kidney disease is educating the primary care physicians. My question is, will the MGFR be available to primary care physicians so that they can diagnose the kidney disease earlier than go to the nephrologist at a later stage?
Get closer. The first generation of the device is focused on hospitals, and there's a protocol that we tried to assess what kind of care environment would accept that protocol. So they've got to be able to dose the patient. They've got to be able to take timed blood draws. That's probably not something they're going to want to do initially in a primary care setting. We do have second and third generation ideas that we've got some proof of concept on that removes some of that cumbersomeness that we could see it being used in that environment, but probably not the first generation.
Go ahead.
My question is a general question about telemedicine and specifically remote patient monitoring. What can patients look forward to in this area? Remote patient monitoring, where the physician is here, the patient is there, they're using a tablet or another form of technology to monitor progress and make predictions and such. To any panelist or anyone who knows.
Me off.
Using technology such as teledocs or telemedicine is a useful and valuable sort of tool. And I think specific to transplant patients, they'll be in the centres for, and depending on what centre you go to for a defined period, and then you go out to your community nephrologist. And for some patients, they are in more remote sort of rural areas where they may not have that access to that regular contact. So I do think it could be a vehicle for that. What we do is for example, with our testing services, we have mobile phlebotomy will go out to remote areas and provide that as a service. So I think as you think of not just teledoc or tele services, how do you get access to services for people who don't currently have access to those? And I think of more holistically. So I think from our perspective, one of the things we're looking at is how do you get sort of blood draw services. So that's one thing that we've been addressing. But I do think the question is one that's, just addressing where technology is going. I mean, we're an advancing society. There are so many different platforms we can leverage. So I think it probably wasn't a natural question that I was thinking of to come up from the audience, but it's one I think that's pertinent in terms of how we think of technology.
Just to add to that, certainly not a medical professional, but I was out at the Ideas Conference a couple of weeks ago, and a lot of several of the winners from Kidney X were there. There is some innovation coming down the pike that will allow for what you're talking about, the monitoring and things of that nature. There is a lot of innovation that I think should be here in a short time. Again, I'm going to say this, I want to be very clear. As patients, we have to push forward. We cannot accept the status quo. We have to push forward aggressively about it, or else it's not going to happen. So, we're always fond of saying, my colleague Paul Conway is fond of saying that patients drive innovation, and we do. And I'm going to make a plea for many of you to register. We have a voter registration drive to get our voices heard. The more people we have registered, the more power that we have to have a much stronger impact on the people who are in control of those decisions. Yes, ma'am.
Hello, everyone. I just want to know, how can we assure patients are getting transplants when some centers deny patients due to their income, insurance, and money in the bank? Before a patient even is seen at a transplant center, they go to that orientation. If they don't have enough money in the bank, or they don't have proper insurance, they don't have Medicare, they're already denied. So they say, why go? Why try?
Good question. The question to the panel is, how can we help, what can we do to address patients that cannot get a transplant because of lack of income?
Lack of income, lack of insurance, and the stipulations that some centers, transplant centers, put on patients that if you just have Medicare, if you don't meet that 80%, you're denied, and then they want you to have enough money in the bank to see that you can afford the immunosuppressant drugs after 3 years. So patients are sitting there on dialysis saying, well, I was denied because I don't have $50,000 in the bank, or I don't have $30,000 sitting. Who has that money just sitting in the bank, just other than Trump? I mean, just sitting there.
Okay. Does anybody want to take a shot at it? I don't know if that's the purview of our group here, but.
Well, it's the transport. What do you get transport area?
So I think one of the things that we want to achieve in transplant is to help people overcome those specific barriers. So I know that there are organizations that provide grants for what you're talking about, for the money that has to be put in escrow in order that you can show that you have enough money for your immunosuppressants afterwards. I think also when looking at your insurance coverage, if you know at an early point that you want to go in the direction for transplant, you want to avoid the last minute disappointment. So you want to know, what do I need to do in order to get there? And that's a little bit the networking bit. So who can you pull in order to get to overcome those specific barriers? And I think those are very tailored solutions that we can help you with, find for you. But you have to take charge of that yourself because it's a very specific situation. But I think with education, I think I'm not saying that we can overcome every obstacle, every barrier, but as much as possible. And it's just starting to plan for that as early as possible will help you, or a lot of people, overcome that specific barrier.
Fundraising.
Exactly. That's one of the things.
That's what you're talking about.
Yeah.
Okay.
Yeah.
Thank you. Go ahead, Dave.
Good morning. My name is David White. I serve on AAKP's board, and I just wanted to support that response by talking a little bit about the immuno bill, which comes up every year. We hope that it's coming up this next congressional session. Every year we get a little bit closer, and we are really confident about it passing this year, if not this year, the next session. Rob Glazer of the Renal Physicians Association is fond of saying advocating on the Hill is like building a house brick by brick. So it takes time, it takes patience, and it takes design. And that's another reason, as our president just said, to sign up and be a kidney voter. Every vote counts.
Thank you, Dave.
My question is for Dr. Newell. You know, we talk about the tremendous differences in wait time depending on region of the country. And in the more populated areas, generally, the wait time is the longest. Well, we usually say medical care is better in the highly populated areas and communication is stronger, yet these wait times are so long. So what's the major driver behind that? Is it that there's not as many donors per 100,000 people that are available in those areas, or people don't donate? You know, you would think just based on better medical attention and better communication that there'd be more awareness to be donors, either living donors or deceased donors, and you would think that you would have better care for people with kidney situations. So why is there such a difference?
Well, I tried to stay away from that because it becomes a bit political. What I'll tell you is my assessment. I'll try to say this in a non-biased way. I think that there are areas where medical care is better. And what I was trying to say about the state of Georgia is many people never even get referred. And so, yes, it looks like you get transplanted faster in Georgia because so few people get through the system. In the New England area, people are much, much, much more likely to be referred and listed. So they list a higher percentage. If you just look at kidney disease, a higher percentage of people who are eligible for transplant are listed there. So that makes the waits look artificially longer. For your average person with kidney disease, I'm not sure the wait's longer. It's just in Georgia, it's kind of, those people never even have a chance. So I think we have to fix that in our state, first of all. The other thing I will say, and it's contentious, but if you look at those 58 or whatever DSAs, they're all different in how well they manage the donor process and how many donors they get. And there are differences probably in people's ability to donate based on where they live. But if you look, the argument I use, there's a group called Donate Life America, I'm sure familiar with. It encourages first-person authorization. So I don't know if I'm a good donor or a bad donor, but I can say I want to be a donor if I ever can. That's a powerful tool. The rates of first-person consent for donation vary hugely across the country. Now, I won't call out the areas where it's low, but the areas where it's really, really high, like in the Pacific Northwest, have the shortest waits. And I think it has to do with, obviously, if there are more people willing to donate, the wait's going to be shorter. And one of the concerns with the broader sharing is the penalized groups like the Pacific Northwest, where you'll say, well, the wait there is really short because you have more donors. And rather than everybody trying to get to the point where there are more donors, it's easier just to kind of put a Band-Aid on the problem by shipping some of those organs around. So that's an oversimplification. I don't mean to endorse or not endorse anything, but it's a concern that's voiced. So I think it's both. Better access to care means more demand, and if there's less supply for whatever reason, it creates those disparities, I think.
I do want to say, I do think there's been an increase in the overall number of organs available, if you look over the last 5 years for kidney, for example, and I think, the living donor component has sort of plateaued out, but they're looking at some increases now. But maybe commenting on the availability of high-risk patients and organs. So I think if we look at the evolution of treatment for Hep C, for example, so there were donors that weren't, organs that weren't considered if it was Hep C positive, but now that's changed with, treatment for patients that are Hep C positive. So I think there is an opening or creation of a pool of organs which were broader than before. There was also the first HIV organ that was done HIV to HIV. So I think there's a broader pool. I don't know. The problem is it's a 100,000 wait list. That hasn't changed since the time that Dr. Newell was president at AST back in 2014 when I looked at a publication he gave to today. It's still over 100,000. But I do think there is a pool that has broadened out some of the possibility of looking at some high-risk organs which are now available.
Thank you. Go ahead, Miss.
Good afternoon. My name is Karen Solomon Edwards. I'm a former transplant recipient. And my question is to the federal agency that is responsible for providing funds to the facilities that provide hemodialysis regarding quality assurance and compliance. Is there any process out there monitoring the facilities to ensure, one, that the nephrologists are meeting the requirements of seeing the patients in the clinics as they should, and ensuring that HIPAA is being met? My experience in the facilities, the nephrologist rarely came to the facility sites. They sent physician assistant or nurse practitioner, and then the quality of care. That is a big concern that I have, and I think that needs to be addressed.
To answer that, I think it might have something to do with state regulations. I know in Pennsylvania, the physician has to see you once a month. Otherwise, it can be an NP or a PA. And then they do. The state regulations are that for the dialysis center is every 6 months, their visit. And then the nephrologist meets with you at least once a month, more frequently, usually. The PA or the NP is there weekly at least. They're always on call for you. And I've been in the center both pre-transplant and post-transplant and never had any problems whatsoever getting a hold of the doctor and being seen if that's what I needed, and one of the others couldn't take care of me. So I think that might be a state medical issue as well.
Okay. And well, thank you for jumping in there and giving us that response. The observation I'm going to make is the reality is that all dialysis centers aren't created equally, and there is a difference based on where the facilities are located. So, I mean, let's just be upfront about that. Now, one of the things that we do have in place is that we have the networks in place. Is anyone here from a network? Hi, Renee. Renee is with Network 5. Disclosure, I am on the board of Network 5. And one of the things that the networks do, they're funded by CMS. They do have, is it oversight over the facilities with respect to that? In terms of if a patient has an issue, they can at least call you and you would investigate it. So I want everyone to be aware of that. And if you're in a facility, sometimes it's difficult for you to say something that you think might elicit some type of negative retribution. So that's why you work with your network. And, you know, one of the challenges that we have is the system. There are so many separate parts. Since I've been with AAKP, we've had the opportunity to work the full continuum, and we'll be doing that, working with the networks. They have a role in helping patients get on the wait list. So there's a lot of moving parts here, a lot of information. They have a booth outside, and I encourage people to join other organizations that can help out. Yes, ma'am. Why don't you go ahead? She's sitting right there. Where do you live? Where are you from? I live in Washington. She's sitting right there. She can take care of you. D.C., Virginia, Maryland, and West Virginia. How are we set for time, Diana? What does that mean? Say. Name names. Okay. Well, I want to thank the panel. Would you give them an applause? I think they provided us some tremendous information. And now, I'd like to introduce Mr. Kent Bresler, our next moderator. He will moderate our final general session this morning, then you guys get a break. Kent is a member of the AAKP Board of Directors, and he's also an ambassador from the great state of Texas. In 1982, Kent was diagnosed with FSGS, which causes kidney failure, and in 1985, he received a kidney from his brother. I'm happy to say that Kent's kidney is going strong 30 years later, as he is, because he just celebrated his 50th anniversary. I'm going to name names. I want to congratulate his wife, Kathy, who's here with him. And Ken is currently, what else are you participating in? He's participating in chronic kidney disease research reviews for the U.S. Department of Defense, as a mentor for potential transplant recipients, and founder of the Kidney Transplant Solutions, which helps individuals throughout the transplant process and educates on preemptive, which he had the great advantage of having, on preemptive transplantation, which is an opportunity to receive it beforehand. I'd like to welcome to the stage my friend, Kent Bresler. It's all yours.
Thank you. Thanks, Richard. It's truly an honor to be a member of the Board of Directors for AAKP and be part of today's meeting. As an RN, a kidney recipient, and someone diagnosed with FSGS roughly for 40 years, it's a joy and a privilege to be part of the focused emphasis that kidney care is now reflected in our latest executive order. This is the first time in my lifetime that I've seen the amount of effort that's going to go forward and the amount of innovation that's coming forward, and it's a pleasure to be part of that program. So I want to start by introducing our next session members. And our next, this is Advancements in Kidney Care, What the Future Holds. Our panel speakers are Dr. Bruce Colton from CVS Health, Dr. Ramon Mendez from Somatis, and Dr. William Fizzle from Medical Director of the Kidney Project. As with our prior two sessions, each speaker will present in the order introduced, and then we'll reserve questions for the end of the session. I'd like to turn it over to Dr. Cullen now.
Thank you. How are you? Nice to see you.
Good to see you.
Thank you so much. And thanks to Richard and Diana and the organizing committee for inviting me here. And I'm humbled to be in front of the many patients in the room today. What I'm going to talk about today is what CVS is planning for treating patients who have kidney disease. And we've been thinking about this for only 2 years, primarily. I've been thinking about it for over 20 years, but CVS has been thinking about this for 2 years. And we are an official company called CVS Kidney Care for only a few months now. But we've been talking to a lot of the community. We've been talking to a lot of patients, a lot of you, a lot of key stakeholders within the kidney community. And we've recognized some challenges in the kidney care space today. And as we've been looking at those challenges, we've been thinking about how can we develop some products to solve for some of these challenges. And what you see on this slide is actually a very, very superficial look at some of the challenges that exist today within the kidney care space, especially for patients. And there's no way that I could get up here and talk about the challenges that each of you feel. But what we have heard, and we've also heard today, is many patients don't know they have kidney disease when they have advanced kidney disease. Some patients find out when they're in a hospital and they're told they need dialysis. We know that many patients find it very challenging to manage their disease. Kidney disease often coexists with diabetes and high blood pressure and heart disease, and sometimes heart failure. There are many different medications, many different physicians and nurses and social workers and dietitians that many of you have had to see. And patients are usually and frequently not given a choice about receiving a transplant, and often not given a choice about receiving home dialysis. So that means for us that we need to develop a program that's directed to improving consumer understanding, and I say consumer intentionally, and empowerment around your disease. We think the world is moving in a digital way, and we know that digital applications are going to be very important to help you. And we also think we can't lose that face-to-face component. So whatever we do for those important discussions, it has to be done face-to-face. And any discussions around transplant or dialysis modality, that has to involve face-to-face discussions, and oftentimes it has to involve care partners. So I'm going to go aside, just step aside just for a second, and I won't be too long. I know we're running short on time, and I'll look for Diana to give me the sign. But tonight I'll probably go to a restaurant. I will open up an app. I'll look for a restaurant. Maybe I'll choose American food. I'll search for what's open for the time that I want. I can go and find out reviews about that restaurant and choose a time and go there and get seated. Now imagine a world where if I wanted to go out to dinner tonight, I was given a phone number for American food. I called and they said, well, you can only get in 3 months. I can't find out what type of food they have, what type of reviews they have. When I go there, I have to wait. For how long, I don't know. When I sit down, the server stares at a computer and takes my order and never faces me and talks to me. That's what exists today in healthcare. We don't put up with that with ordering our food and going to restaurants, but that's what we put up with in healthcare today, and that has to change. Now, we also know that in addition to addressing some patient challenges, we're not going to make any progress, sadly, unless we also address some challenges on the payer side and also on the nephrologist side. I'm not going to run through these today, but what I will say is that we acknowledge that the economics have to work. And I think the administration is making the right moves to improve transplantation, to improve home dialysis, to improve patient education, and recognizing that in order to really change the status quo, then you need the economics to work for other stakeholders. That includes payers, but that also includes nephrologists. What I would like to say is even though we're a company that's about 2 years old, our kidney care business, we have the assets of a very large company. And that makes what we're trying to do actually quite a bit easier at times. So if you think about it, we have about 10,000 stores and 5 million people walk through our stores every day. Can you imagine the impact that might have on increasing awareness of kidney disease? Right? We have 30,000 pharmacists who are happy to talk to you. I don't know of any other person in healthcare, any other professional, where you could walk in off the street without an appointment and ask a question about your health. Now, they may not spend a lot of time with you because they have other work to do, but they'll actually talk to you about your health and answer questions about a medication that you might be picking up over the counter, if that's going to affect my kidneys or not, without an appointment. We also have minute clinics. We also have infusion clinics, and we also have relationships with a lot of payers and health systems around the country. A little while ago, we acquired a small company called Aetna. They really know how to manage medical risk. They understand risk, and they understand about achieving outcomes for patients and lowering costs through better care. And we recently announced that we're expanding something called health hubs. And we launched a couple of these in Texas, primarily in the Houston market, where we changed what a retail store looks like and put 20% more focus on how do we manage chronic disease. And there's everything from durable medical equipment to places for education classes, even for yoga, and even for health concierge to help you through your insurance questions. And so we're opening up 1,500 more of those across the country over the next 3 years. We think that's also an opportunity to help patients with kidney disease. Now, the way we've been thinking about our new business is we're trying to create a solution that's end-to-end, meaning that we want to help identify patients who have kidney disease and don't know they have it, to also assist in the management of kidney disease, but also to become a dialysis provider. That's right, to be a dialysis provider with a focus on home, but also to get into device manufacturing, where we're actually making a new device and taking it through clinical studies to allow patients to do more home hemodialysis. We believe PD is very important, but we also think that more patients can do more hemodialysis at home if given the right opportunity. I'm not going to talk about that today. I'm not going to talk about our provider development, our business development within the provider space today. I'm just going to focus quickly on CKD identification and management. So this is what our program looks like. And I'll take you through some of these, but what you see at the bottom of the slide is what you've already heard today. We want to delay onset of kidney failure. We want to slow progression of kidney disease. We do not want patients to move into stage 5 kidney disease. We don't want them to move into stage 4 for that matter. We'd certainly like to keep people off dialysis. We want to increase the number of transplants. We want to grow home modalities if patients do end up needing replacement therapy. And we want to increase the % of planned starts. That only comes with identification and education over time. And I think Richard put that nicely this morning. Now, how we're thinking about doing this is we do have a group of folks that are nerds. They're very smart nerds, and they deal with data all the time. And they're looking at all the data that we get in from either the pharmacy or through medical claims and sometimes through lab claims and other data pulls that we can get. And they're able to not only identify patients who have kidney disease, whether they know it or not, but also identify patients who may be at risk of kidney disease and haven't been tested. And so we're developing programs on using that capability. And not just that, but they're able to identify patients who are progressing faster than others so that we might be able to intervene in a different way. And then we have a program we launched in April. We have renal trained nurses who are reaching out to those patients who have kidney disease and asking, how can we help? And I'll tell you a little bit more about that in a slide or two. We also think the face-to-face component is important, as I mentioned. There are certain conversations that you just can't have over the phone. I have 3 minutes. And we also think that digital movement is going to be very important for us to be successful as well, much like that example I gave you for wanting and choosing a restaurant for tonight. This is what our CKD program looks like today, with a nurse on the other end of the line who reaches out to a patient. And I can tell you it's not just focused on, do you know what your blood pressure is, and are you on an ACE inhibitor? It's a lot more than blood pressure. It's a lot more than controlling your diabetes. It's also empowering a patient to be more engaged in their whole health, to understand what some mental health challenges some people may have, to understand the impact of social determinants of health. How can we help you navigate through the health system? How can we help you ask the right questions when you go to see your nephrologist? And how can we make sure your nephrologist has all the data there so that they can make the right decisions? So we launched this in some selected cities back in April. We're expanding it. That was just a pilot. We continue to sort of modify our program and our analysis of the data. But this is what we've been seeing so far from our phase 1, again, launched earlier this year. So some of the big take-homes are most people that we've reached out to have a nephrologist. That may change over time as we start looking at different data pools. Most of them have a nephrologist. Most people don't know what caused their kidneys to fail. Few have had any dietary counseling, although that seems to be one of the most important things on the patient's mind when they call in and talk to our nurse. Only some recall any conversation about renal replacement therapy. Most people think in-center is the only option. And everyone wants to include caregivers and spouses in the discussion. So those are just some of the learnings. At some point, we'll be able to give you more of a quantitative look at what you're seeing, but this is more of a qualitative review of some things we're hearing from patients. And I'll leave on this slide, and I'm not going to go into any details because Richard did talk about this morning as well as other speakers, other than to say that I'm pretty proud that, you know, even though we started thinking about this 2 years ago and the executive order only came out a couple of months ago, we're pretty proud that we line up quite well against many of the things that were in the executive order. And to us, that also means that CMS and HHS are thinking of the right things in trying to incentivize proper behavior in an industry where the status quo is no longer acceptable. Thank you.
Hello, good afternoon. It's already afternoon. It's a pleasure to be here. Congratulations to the AAKP on their 50th anniversary. I'm very excited to be here with this audience because you can feel the change. The winds of change are blowing in kidney disease and kidney care. And we at Samatas are so happy to be part of that change. What is the future? Already, at Samatas, we're beginning to build on that future. Now, as Bruce so well said, the status of kidney care is nothing much has changed over the years. Since I was a fellow in the late 80s, we're still doing things with my fellow here in the audience, Dr. Grossman, and nothing much has changed over the years. And we know that to keep doing the same thing over and over and expecting a different result is insanity. So I'm so glad that finally the stars are aligning. And we have the executive order, we have private payers, we have different health organizations, and especially you working together to bring the change that we need. So I will discuss how we at Samatas are implementing the future of kidney care. So who are we? So Somatis was founded in 2016 by Dr. Ikenna Okizi, a physician and former DaVita executive. And we're a local company just across the river in Tyson's Corner. And we've grown from 3 employees in 2016 to currently we have slightly over 130 employees. And what is our mission? Well, it's very modest, just to be the world's best provider of integrated care delivery for patients at risk or with kidney disease. So the entire spectrum, and integrated because it's going to be it is the complete picture. And what do? Well, we actually take total accountability for patients throughout the entire spectrum of CKD, from diagnosis, but including dialysis, transplantation. And we implement evidence-based therapies. There are many things that we can do, but are not being done consistently to reduce the impact on progression and even actually stopping the progression of kidney disease in some patients. And we improve coordination of care. So we fill in the gaps between the various providers so that the care is seamless. So this is what value is. We are improving outcomes, but at the same time reducing cost. And that's why we're now the largest value-based kidney care company in the market. So we work with health plans, with various hospitals, health systems, nephrologists, primary care, and especially with you, patients. So we started out, our first contract was with Inova Hospitals, again, just across the river in Northern Virginia. It's the biggest hospital system in Northern Virginia. And we started providing inpatient dialysis care. And so far, we've done approximately 29,000 dialysis treatments since we started in 2017. And we provided transplant, again, one of the basic levers that we believe in is increasing transplantation rate. And in that focus, we have increased the transplant referrals to the transplant program at Inova Fairfax. And we provide quality. We've had 10 audits on surveys with 0 deficiencies by the Joint Commission or CMS. And we provide education. We've heard prior speakers speak to the need for education. We need to provide that information and be readily available. But we don't only do inpatient care. In partnership with Inova, we're also doing outpatient dialysis. And Inova is our joint venture partner, and we've opened 2 centers in Falls Church and 1 center in Alexandria. That center is in the campus of Mount Vernon Hospital. Okay. And these centers look like this. So this is our center at Mount Vernon. And you'll notice it first, the light. This is how we think. We think that centers should be uplifting. And also notice the privacies between the different chairs. Okay. Also, something that we believe in, we said transplantation, but also we think home therapies should be the treatment of choice. And here we put our money where our mouth is, and the home real estate in our units is equal to that of the in-center. So home is not a room here or 2 rooms, but actually the same real estate. And in Falls Church, we have 1 unit is for home and 1 unit is for in-center. Again, the same real estate. And we also believe that we can do better in terms of quality metrics. So we have adopted KDIGO guidelines for bone mineral metabolism, which are stricter than those for the LDLs, but that we believe will result in better outcomes for our patients. So, okay, you're going to say, okay, so that's great. You do inpatient dialysis with good results. Your units look wonderful, but how are you different? So that's where our model comes in for total CKD care. And here, our goal, again, much aligned with the executive order and what really is the right thing to do, is to actually delay or stop progression of CKD. And that can be done in many patients. We know therapies aimed at hypertension, certain classes of agents can protect from or slow down the progression, yet these medications are utilized in less than 50% of the appropriate patients. We also have new therapies, 2 classes of drugs to treat diabetes, and these drugs have been shown to have cardioprotective and renal protective properties, yet they're utilized in 10%, less than 10% of diabetics at risk. Yes? So these are the GLP-1 agonists and SGLT2 antagonists, of which there are several on the market. So we have, and then of course there's education and nutritional education. Diet does make a difference, and there are multiple areas of education which can improve the outcomes. But if the patients do progress despite our best efforts, again, we believe that transplantation is as close as a cure that we have. And we should actually encourage preemptive transplantation is the ideal. If they need dialysis, well, again, we're PD first organization. We believe that home therapies provide the best quality of life and also the best outcomes for patients. And we also believe that many patients are started actually too early on dialysis in the United States. By some estimates, at least 40% of all the patients in the US start dialysis at a GFR above 10. And that's not in general with the KDIGO recommendations for initiation of dialysis. We believe that patients, if they start dialysis, it should be planned starts. Patients don't need to go to the hospital if they're stable to start dialysis. There's no reason for that. And of course, if they're doing hemodialysis, they should have their access so we can avoid the central venous catheter. And then we also address the different determinants of health that are obstacles for the ideal care for the patients. Things like obtaining their medications, transportation issues, and so on. And how do we do this? Well, we have our own technology called Renal IQ that helps integrate care between the different providers, helps stratify the risk of the patients for complications and progression, and also, I will show you later, developed an app that the patients can use. But I think the real key difference here is that we have field-based nursing teams that actually go to the patient's home to look at what their situation is. So every patient has a different situation, and when they go to the office or the dialysis unit, they may not be telling you everything that's going on. So by going to their homes, 1, you develop better rapport with the patient, and 2, you can actually go over the things. You can look at their fridge or their cupboard and see what kinds of food they have that they may not be telling you. So this is crucial to bridge all these different determinants of health that impact the care of the patient. And we believe in a patient-centered approach. So every patient has different values, what is important for them. So we actually listen to the patients and try to work with them for them to achieve the goals that they have for themselves. Okay, and we collaborate with all the different companies to try to provide a seamless integrated care. This is what the app looks like. This is for a patient, with that is on dialysis and is on the waiting list for transplant. So you can see that they can keep track of what their evaluation, at what stage they are, what they need to do. You can keep track of appointments. You can keep track of what medications you need to take at what time. And you have a call button there that you can reach your primary care leader, not your nurse, so that you can actually talk in real time any questions or concerns that you have. And using technology, we can identify which patients are at greatest need. And these are coded in red. And these are the patients that need more frequent intervention, as opposed to the patients in green who may have a good social and family support, good transportation, and so on. So our team then is made up of a nurse care manager, which is the central person, community health worker. These are the ones that would actually go to patients' home. But we also have a team of pharmacists, dietitians, social worker, pub health director, and manager, medical director, who are available for direct consultation. And we've actually tried this in Tennessee. So this is the first risk-based agreement in the United States, and we've used this approach to take care of the around 400 Medicare Advantage patients of Blue Cross Blue Shield of Tennessee. This started in January of 2019, and I can tell you so far, we have outreached 386 of those 400 patients, completed around 3,500 patient calls, but importantly, more than 1,000 patient home visits have been performed. And many of these patients connected to dietitian and social worker from Somatis, in addition to the one that they have in their dialysis unit. So they continue with their nephrologist, they continue with their dialysis unit. We are filling in the gap in their care. And what are we doing? So we're taking care of things like patients with wound care, taking care of their travel needs, taking care of other medical testing that many times falls through the cracks. We encourage transplantation. We help with their medications, not only getting their medications, but actually reviewing all their medications. You know how people bring in a bag with all their pill bottles and say, well, you have 2 of the same, these 3 are very similar. It's so important. And then we help also with their dialysis, getting them appointments to get vein mapping, to get to the surgeon, and actually encouraging or at least providing education on how they can transition to home therapies. And finally, food and nutrition, all important for kidney disease. Okay, what about so far? How are we doing? Well, actually, all those 400 patients, 87% enrolled in the program. So this is way above the industry standard, which is around 50%. And I'm told that many of the patients, when asked, they say, what? This is free? I don't need to do anything or pay? No, yes, this is all available through your health plan. Okay, 100% of the patients have received transplant education, and many of them have been referred for transplantation. And so far, as compared to last year, we've seen reductions in the cost. So again, improving outcomes and reducing costs. But I think these are numbers. I want to show you a patient story, very personal thing of what we're doing in Tennessee. And this is a patient that had all these skin lesions and had seen a dermatologist, but without any resolution. So he was giving up. He said, you know, these are too painful. I'm not going to dialysis. I'm going to the hospital. So our nurse care manager took pictures and actually sent them to me. I said, I really don't know what this is, but he needs a skin biopsy. So they got an appointment for the next day with an in-network dermatologist. The patient got his biopsy, and a bullous pemphigoid was diagnosed. This is a disease treatable with steroids, which he got. And these are the results. So also notice that he has a CVC in the other picture. So now, because his lesions have cleared, he was able to get an AV fistula. That matured, and now the catheter is out. So a success story. Now we need to work on the Mountain Dew addiction. So we need to change the way we do the usual care to get better results. So at Sematas, we're trying to do that and hopefully get the results you deserve. Thank you.
Hi, I'm Bill Fazell. I'm the medical director of the Kidney Project. Just a quick show of hands. How many of you have been lulled to sleep by my presentations before? I think I've given several talks at AAKP in the past. Diana warned me that I only had 10 minutes, so we're going to do something a little bit different for this talk. All of my prior talks have been 55 minutes of graphs and slides and data points, speaking from the head. Today, since I only have 10 minutes, I'm going to speak from the heart. It's going to be a little bit different. So I'd like to congratulate AAKP on 50 years. It's a phenomenal thing to be advocating for patients for a half century. And it's also an anniversary for me. So 50 years ago, a 2.5-year-old child was discharged from the hospital for the first time. I was born in May 1966 with kidney disease. I've been a kidney patient in my own way ever since. And so while NIDDK may have decided that come to the table, I think, as Paul Kimmel said, late to the dance about patient engagement, I've been deeply engaged since May 1966 when I was born with kidney disease. So Diana asked me to talk about where are we now? And I think we've learned some things in the past half century. One thing we've learned is that when the Medicare entitlement for end-stage renal disease was enacted, one of the bases for that enactment was that the idea there was never going to be a whole lot of people. It's not going to be a big thing, right? So now it's $40 billion a year. It's the same size as the entire NIH budget. So predictions are hard, especially about the future. The other thing that we've learned, to our sadness, I think, is that the promise that the molecular biology revolution was going to unleash cures for us is paying out more slowly than we'd hoped. We have 100,000 new patients a year coming to dialysis. I was on clinical service yesterday in the hospital at Vanderbilt, and every single day I had a new start for end-stage kidney disease. None of them had access. None of them were admitted to the hospital planning to start dialysis, but every one of them was placed into a dialysis unit at the time of discharge. So the problem isn't getting fixed. We still have patients coming to dialysis. The epidemiology of the causes of end-stage kidney disease are evolving over time. Angiotensin blockade has blunted the incidence curve for sure, but we still have pretty big problems to address. The other thing we learned, this is data from Robert Pauley. When I was in medical school, when I was a resident, I think we were lulled into complacency about the mortality rate on dialysis. I was, a little wet behind the ears, thinking about my own future. I said, to my attending physician, why are these people dying? Why are there all these dialysis patients in the hospital? And the first thing he said was, well, first, they're not dialysis patients, they're people who happen to have kidney disease, Bill. And the second thing was that he said, well, these patients come to kidney failure at the end of a long sequence of chronic diseases, of high blood pressure, of diabetes, of autoimmune disease. It's normal for them to die. I think we've learned, some from our experience north of the border. This is data from Robert Pauley comparing intensive maintenance dialysis to survival of first deceased donor and living donor renal transplants. And the remarkable thing is that this funny little bundle of plastic fibers that you all know too well actually can confer health. It doesn't just delay death. Part of the morbidity and the mortality of end-stage kidney disease stems in no small part from how dialysis is prescribed. And so Jenny Flythe at UNC or Chris McIntyre, thank you, he's cueing me here, Chris McIntyre now at Western Ontario, showed that the roller coaster of fluid accumulation and then sudden plummet actually drives cardiac stress, cardiac scarring in patients on dialysis. So I think we've learned that the benefits of transplant in terms of survival may not be entirely contingent on getting an organ. It may be related to the fact that you don't go through this roller coaster of ups and downs. You don't have a starvation diet of celery and cardboard, that you're actually able to eat food. And so that unveiled something to us. We recognized 20 years ago that, no disrespect intended, but working around the edges of kidney allocation schemes was unlikely to solve the scarcity problem in organ transplant. So we moved on to say, well, maybe we could do it through biomedical engineering. Everybody has the horse that they ride, and I'm an engineer. So we're going to make a universal donor kidney. We're going to follow the model that Mother Nature set for us with 60 million years of research and development. We're going to have a high-efficiency filter, just like the kidney glomerulus, and we're going to have a lawn of cultured renal tubule cells to reabsorb salt and water, just like the proximal tubule does. We can't grow a kidney filter yet. Maybe basic science innovations will lead us that way someday. But we can't grow one that will function. So we're just going to build it. And we're going to build it by changing the underlying technology we use to make filters away from the hollow fibers that have been the basis of renal care since the early 1970s. On the other hand, we don't know the identity of the toxins that make people sick. So yesterday morning, I said, Mr. So-and-so, you hold up your hands. And the patient did this. And I asked my renal fellow, what's the molecule that's doing that? Kind of deer in the headlights look. And the answer is nobody knows. We've been dialyzing patients for over 60 years, and we still don't know the identities of the molecular mediators that cause illness, that cause the residual syndrome of dialyzed renal failure, that cause uremia. But we know, or at least our kidneys know, because I'm not flapping, because my kidney's tubule is able to distinguish between waste products that need to be excreted and valuable metabolic substrates that our body needs. So let's use that. Use the chemical energy of ATP hydrolysis to pump salt and water and liberate the patient from being plugged into a wall outlet, being tied to the water room. So all we did was we changed the underlying technology. We made our membranes using the same technology that came out of the microelectronics industry. Being able to dictate the architecture of the pores of the membrane allowed us to increase the efficiency of the membranes so the package size can get down small enough to be tucked inside a human body. And that we can rely on cardiac perfusion pressure alone to drive ultrafiltration, just like your kidney does. And that frees the patient from electric motors, wall outlets, and pumps. And so now, just to get you all warmed up for lunch, we've now gotten to the point where we can routinely implant silicon membranes into experimental animals and have them produce a watery ultrafiltrative plasma for weeks on end without thrombosis, without fouling, without failure. So the first part of the equation we've made a lot of progress on. We've developed the first new filter since the 1970s, and it's fundamentally enabling for an implanted device to take care of patients who really desperately want an alternative to in-center dialysis. Oh, I got some noise there in the slide. So the other thing we began to focus on was the cells themselves. We know that for the most part, kidney cells cultured in a dish don't look like the cells in a person. They're kind of stressed. They look like fried eggs. And so we experimented with a couple of different basic bread and butter culture conditions. It was not a mechanistic investigation. It was just, hey, let's try this, let's try that. And we got cells to express the molecular transporters that they need to move salt and water, published that. And in unpublished data, I'm happy to share with you that now I think this is unprecedented. Our cells are moving salt and water from top to bottom faster than our cell culture techs can replace fluid in the cell culture dish. So we've knocked down the two basic elements of an implantable artificial kidney. That we can have a filter driven by cardiac perfusion pressure, and we can have a bioreactor of cultured kidney cells that will return salt and water to the patient's bloodstream and concentrate waste products down into a little yellow juice that the patient can pee into the toilet bowl. That's the progress that we've made. So I'm going to look back for a moment. 20 years ago, when I was interviewing for renal fellowships and for jobs, I'd tell them I really want to do this, use silicon nanotechnology to build an implantable artificial kidney. You can imagine how that narrative went. People looked at me as if I told them my career goal was to become an eggplant. And the answer that I got was, well, you do realize that the problem is much more complicated than that. So the notion of complexity and that we need to understand every single mechanism to be even able to take the first step dominated the field. And so that reminded me of a quote from Barry Marshall, who said, "Everyone is against me, but I knew I was right." And since the early 2000s, we've been knocking down about one supposedly impossible thing every 2 years or so. And as I showed you, the first new membrane is now implanted and working. We've shown that our kidney cells transport salt and water just fine, thank you. And we're now at the point where we're ready to start first-in-man studies of our technology, particularly the silicon filters, pending kind of final negotiations with the Food and Drug Administration. So that's where we are now. I want to share with you a couple of the speed bumps on this journey. This is a grant that was reviewed this year at the National Institutes of Health, and I'm going to read it aloud. Steady, slow progress over the last 10 years. The work to be done is not a paradigm shift. The approach is logical, the milestones are stated clearly, the proposed approaches are based on a solid foundation, and alternatives are proposed. It is likely the team will make progress and accomplish much of what they propose. Nonetheless, this is not transformative. This grant didn't even receive a score. It was so bad that it didn't even receive a score from the study section, because it wasn't about mechanism. It wasn't discovering new scientific facts. And I want you to pause for a moment and think about the hubris of that attitude. That dedication to intellectualism and discovery and publishing one more scientific paper to molder in some electronic warehouse somewhere that nobody is going to read somehow has more priority than doing work that they acknowledge themselves likely will make progress and accomplish much of what they propose. Who's the guy on the left? Anybody know? Anybody recognize that face? So, milkmaids have been a sex symbol for many, many years. And milkmaids were a sex symbol because they were the population whose faces were not scarred by smallpox. Because cowpox conferred immunity to smallpox. And the man on the left is Edward Jenner, who vaccinated from the vaccinia virus his own son and others with cowpox to prevent smallpox. He did not have to come up with detailed 20-year analyses of the evolution of the T-cell repertoire of the patients. He made the single greatest step that has probably saved lives on planet Earth. The guy in the middle, anybody recognize him? Yes, John Snow. Very good. John Snow was looking at a cholera outbreak, and John Snow looked at where the cholera cases were, and right in the middle of the map was a water pump. And so he walked down and he took the handle off the pump. How would that go in a study section today? Well, you only have you're proposing a sample size of 1, sir. Tell me about your statistical analysis. You know, did you conduct an in-depth analysis of the impact of walking over to the next pump on the families in the area? No, he just went, he took the handle off the pump and stopped the epidemic. And Kolf is the man on the right, the first person to successfully dialyze a human patient who survived. We talk about that, but we don't talk so much about the 14 people who got dialyzed by him who didn't live, right? Get that through the IRB today, right? But every single one of you are alive because he took that step. And I'm going to have to take that step someday myself. I owe a debt of gratitude to him, okay? So John Hunter is kind of as a surgeon trained with William Harvey, and he had one of the great statements of the Enlightenment. Don't think, try. This is an alternative to the kind of navel-gazing philosophizing about what was logical. Just go do it, try it. Be precise, be accurate, be kind. But don't just sit with your pen and your paper and think. Go try it. And so we'll close with Richard Knight, who said something this morning that I agree with completely. When challenged with this statement, they say, well, it's not that simple. Oh, yes, it is. Just put your foot down and make the progress and get there. And I'll close with Pim Kolf. Says, it's nearly impossible to obtain funding for something simple. Therefore, over the years, my laboratory has teetered along, always on the rim of bankruptcy, always having too many ideas and too little money to carry them out. And that's the boat that I'm in today. I have 0 NIH funding as of today. So that's where we are. We'll soldier on. Thanks for your attention.
We will soldier on. That's right. Okay, thank you guys and for your presentations, and now we'll take some questions. Approach the mic. How much time do we have? 2 questions. 2 short questions.
This is very short.
Please.
We're all here because we believe in public health. I just have to acknowledge Bruce. CVS is one of several companies that have just banned guns from being carried into their store. On the theme of just do it.
Yeah. Yes, ma'am.
I'm a medical social worker, and I have stage 3 kidney disease. I'm proud to be part of clinical innovation and integrated care throughout my career. So I want to urge all of you as clinical innovators and corporations to please fund the Kidney Project. It's really critical that we stand together and that we are not afraid of innovation and that we let go of the old ways of dialysis. My uncle, who was Israeli, came to this country and helped design the dialysis machine that exists today, not knowing that his niece one day may need to have dialysis. I love that what's happening here, and I really urge you to step up and to provide the funding. Thank you.
Yes, sir.
I second her. Question I have is, why not? Because this project, this technology, has the potential to totally change the game in a way that could almost, maybe not fully, but almost delete the need for dialysis or transplant or rejection or anti-rejection medication or whatever. And therefore, in my patient view, which has been emphasized this morning to the nth degree, and I appreciate that, we all appreciate that, I think time has come for whatever reason, by whether it's NIH or whether it's CMS or through White House orders or all of the above, we must do everything we can to push this sort of science forward. It is a game changer, and as a patient and maybe I'm speaking for all of us, this is necessary and more than necessary. It would be a blessing if it is successful, and I think we are there.
Thank you. Dr. Fussell, what would it take from the kidney community to help you right now?
I think there's several things. I think we can all talk about money. And, you know, for 5 years, 8 years, I've been walking in front of venture capitalists and potential strategic partners to talk about term sheets and budgets and milestones. So there's money. Trump's executive order in Section 6 is that it's now the policy of the U.S. government to develop an artificial kidney. It's great that that's in there. 20 years ago, when I was telling people what I wanted to do, it was really on deaf ears, and now it's a subject of national dialogue, and that's in no small part because of AAKP's advocacy for patients. I think that we need a safe space for innovators to collaborate. KidneyX may in fact form that safe space, so a public-private partnership between CMS and the American Society of Nephrology has, I think, partially funded at a moderate level, but also entered the dialogue of saying there's an arena in which people who want to move the needle, not on discovery science, not on fundamental understanding of disease processes, but in addressing the unmet needs of the 500,000 patients who receive dialysis in the United States. I think that's very optimistic, and we need to see high-level federal government support for innovations like KidneyX that challenge both people in the community already and also newcomers to the field to apply their wisdom and their ingenuity to come up with better solutions for patients who are already on dialysis, who have in one way or another either fallen through the cracks or suffered a mishap that no longer have functioning kidneys. That's all great. I think that this is a huge step forward. I hope that we can encourage the federal government to continue to fund KidneyX. I think the first, I don't know if anybody's in the room from KHI or from KidneyX. I think the first contribution from the American Society of Nephrology was $25 million, and CMS stumped up $600,000. So all of this is very small money compared to $40 billion spent every year on direct patient care and dialysis. The field needs money. It may not be my gadget that gets us over the wire, and to a large extent, it doesn't matter if it's my gadget that gets us over the wire. What matters is that we're attracting entrants to the field to think about this, to focus on this, and to apply their ingenuity to helping all of us.
All right, I'm going to take a 15-minute break, and then we're going to transition to an afternoon lunch with our expert session sponsored by Mallinckrodt. This lunch session is located in Congressional A and B on the second floor. Go to the lobby level, turn to the South Tower elevators, and you'll find several starved people waiting for you there at the lunchroom. Okay, you've got your tickets for your lunch and your table assignments in your registration carry-ons, okay? Thank you. We'll see you this afternoon.